in Florida, USA. For the Egyptian experience, we will not have better than Professor Gehan Elasal. Professor Gehan is the professor of pulmonary medicine in Ain Shams University. And of course, Professor Gehan, during the last 4 months, she's the vice president for the scientific committee of combating COVID-19 in the MOH and all over Egypt. She has a lot of things to do, and she is one of the very important pillars in doing the Egyptian protocol against COVID-19. I strongly suggest that both of them will give us very important talks about what is happening in the United States and in Egypt as well. Rahab, further.
In today's gathering, I'd like to focus on our new topics as per agenda. First, EVA Pharma introduction through Dr. Ziad Armanious. Then we will talk about COVID-19 treatment guidelines through Professor Ziad Mattar, and phases of Egyptian protocol against COVID-19 with Professor Gehan Elasal. Finally, we will take a question and answer, and we'd love to hear from you all questions to answers from the speakers will be managed by Dr. Ahmed Misbah. Well, I don't want to take too much of your time. I need to leave some time to Dr. Angad to welcome all the speakers. Dr. Angad, the mic with you.
Good afternoon, our dear guest speakers and our dear guest healthcare professionals. Ladies and gentlemen, Happy New Hijri year. And we wish that 2020 mistakenly suggests or thinks that it left. So everything is left behind us and we start all over again as a new year. I'd like to thank Professor Dr. Ashraf Hatem, whom I know personally for so many years. And of course, he's very well known to be very scientific and supporting to research and development, and a true real clinician who treats his patient on evidence-based medicine, for being the chairperson for our scientific event. Also, Professor Dr. Ziad Mattar, whom I knew through Amr Adib introduction or interview, and I was really impressed by the level of depth of information and knowledge and scientific sharing for his experience with the treatment of COVID patients, and he cordially accepted our invitation to be our guest speaker. Thank you also for Professor Dr. Gehan Elasal, who is supporting all Egyptian patients at all levels through the protocol and guiding everybody towards a better health by her experience and sharing best practice in different hospitals and in managing the Egyptian protocol. I'd like to introduce Dr. Ziad Armanious, our CEO, to speak a little bit about EVA Pharma mission and vision. We are a company of purpose and purpose-driven, and I really always, every time, get inspired by hearing him speaking about our mission and vision, because it's the shared common objective for all of us, which is helping the patients to live a better life. Dr. Ziad Armanious, mic with you.
Good evening, everyone. I hope you can hear me well. So thank you, Angad, for the introduction. Thank you for raising the bar really high. I hope that I will make brief remarks, mainly to welcome everyone. I would like to welcome this august group of clinicians, a gathering of over 500 doctors by now. And I think if I say a few more words, that number might hit 1,000 soon. So where are we today? We hear in Egypt about the second wave. We see a clear second wave in the United States. We see a clear second wave all around the world. I think we've been tested in so many different ways, especially in 2020, especially with COVID-19. We're being tested every day. Our healthcare systems are being tested every day. But for the most part, most of our patients have been given the best fighting chance. And that's thanks to the heroic efforts by many frontliners, physicians, nurses, pharmacists, and all other healthcare professionals. We are trying to do our best as a pharmaceutical organization. We've been working on COVID-19 cures and treatments very diligently. We've worked on all 3 antivirals. We're happy to be, we're really happy to see such remarkable results across the world with our own product, Remdesivir EVA Pharma, in the Philippines to the east, to Panama in the west, all the way north in Turkmenistan and all the way south in Africa. We're seeing significant results. And we would like to recognize and thank all doctors from around the world that are with us this evening. I can see that there is a big contingent from Egypt, but other than the Egyptian doctors that we're very proud of, we have a really big group of doctors from around the world. And I think because of these tough times, I think we will all agree that it will not be just good medicine that is needed, not just good medicine or good medicines, but rather the best collaboration, the best sharing of experiences. The best experience sharing is exactly what we hope to accomplish tonight. I think having this big group of doctors is a testament to the importance of the subject as we transition into hopefully easier times. But I hope as we transition into the second wave, we are ready and we have the best practices at our disposal, best medicines that we are doing our best to provide. And with this, I would like to cut my remarks short and give it back to Rehab. Rehab, you're muted. I'm sure you're saying something important.
Thank you, Dr. Riyad, for your introduction. Thank you so much for listening to us, and welcome Dr. Ziad Matar. The mic is with you. Hello.
Let me share my screen first.
Yes, please.
Oops. Can you see my screen?
No, not yet, doctor.
Okay, I'm not sure what happened.
So you can press Control F5, then you can share it easily.
Okay.
Yes.
Yes. Maybe the F5 has worked.
Okay. Well, first of all, I want to thank EVA Pharma for having me and for all the staff working with EVA Pharma. It's been an honor to know you over the phone and over the internet. I want to thank the panelists for joining us tonight, and for all the audiences. I'm very impressed to see this many numbers of doctors joining for this very important webinar. This is an important pandemic that we're facing, and I'm sure altogether, as Dr. Armanu said, there is a lot that we can do, and I'm sure together we can get through this. Also, I want to say, originally I'm from Lebanon, and this is the first time I address an Arabic-speaking medical community. So, أهلا وسهلا فيكم كلكم, and this is an honor for me to be part of this webinar, and thank you for having me. What we're going to do tonight, we're going to talk about COVID-19 in general, and from a different perspective, and I'm also excited and looking forward to hear your point of view and what is being done in Egypt for this matter. So My objectives tonight are going to be divided into 3 sections. The first section, the shortest part, probably 10, 15 minutes, no longer than that, we're going to talk about the SARS-CoV-2. What is this virus, where it comes from, talking clinically about the presentations, how we diagnose it, and what can we do to prevent the spread of this virus. And then we're going to present a couple cases briefly, because there is a big case I'm going to leave till the end to present. But the big bulk of my presentation is going to be basically about treatment. We're going to discuss 4 major trials, and then we're going to talk about treatment in the US and about some statistics, cases around the globe, and the trends. And then I want to talk also about what is the second wave, is there a second wave or not, and we move from there. So again, the biggest part of this presentation is going to be about treatment. So let's start with this virus that it's part of the coronavirus. It's been known for many years. It's the 7th strain of the coronavirus family. The first 4 are very benign. They can cause mild symptoms, cough, nasal drainage, cold-like symptoms, nothing specific about them. The 5th and 6th, back in 2003 and 2009, they did cause MERS, MERS, and the SARS. And luckily now we have the COVID-19, which is the 7th strain. It's a single-stranded RNA, it's enveloped. And we believe it's spread through bats and pangolins, this funny-looking animal, but mainly through bats, I do believe that. So how is it spread among us, and what can we do to stop this? Because most of the virus now is spread from human to human via respiratory droplets. When we cough, when we speak loud, and we're not wearing a mask to protect ourselves, obviously we inhale the droplet, which is loaded with viruses. And also there is a way to spread it via contact. That's why it's extremely important, hand hygiene, hand washing, and social distancing. The virus, once it's inhaled, it gets inside the alveoli and it sits on the ACE2 receptor, which is a part of the type 2 pneumocytes, with an incubation period ranges between 3 to 12 days. We don't have exact details about this, but the problem is with the viral shedding. It can go up to 20 days, and part of the treatment for COVID-19 is what can we do to stop the viral shedding as soon as possible. And this is the gray zone that sometimes we have trouble finding when the viral shedding starts. So, and I also mentioned about the multiple strains with the COVID-19, which is the 7th strain out of, which is number 7. Sorry. Okay. From an epidemiology standpoint, I'm going to focus here on the case fatality rate, which is the percentage of infected individuals who die from the virus itself. Because with this novel virus, it's been nothing but ordinary, nothing but standard. It's really up and down. It's changing on us on a regular basis. There is constant new information coming in, and the case fatality rate varies significantly from a country to another. And that's why some people will ask why we see more mortality in this country, we don't see it in the other country. And this has really been an uphill battle with it. But it definitely depends on multiple factors. It depends on the testing rate. How many tests have you done? Are you doing, because the WHO recommends certain percentage of testing to be done on a certain population in order to be able to come up with a fixed case fatality rate. Otherwise, it's going to be extremely hard. It also depends on the population densities. That's why we see more COVID most of the time in heavily populated major cities. For instance, in the US, specifically in New York City, which is heavily dense city, in LA, in San Francisco, in Florida, we've seen it in Miami, Again, because of the rate of spread via droplet or contact is extremely high. And again, as I mentioned, it varies from location to another location. So worldwide, the case fatality rate right now, if we combine all countries, is 3.5%. And in the US right now, our case fatality is down to 3. Now, part of this can be related to the lockdown, to the isolation. We've been asking people to isolate themselves to avoid crowded places. And this has worked to a certain degree, but we're gonna go toward the end of the presentation and talk and see some numbers and see some trends about the total numbers. I already mentioned about the incubation period and viral shedding. But at the bottom of my screen here, I wanna stress this point here that luckily, and I say luckily, close to 80% of patients who are infected with COVID-19 are only mild cases. Mild cases meaning they do not need oxygen, they can be treated at home, they can take over-the-counter medications to control fever and cough, and they do not need to go to a hospital or being treated with any medications. Why? Because can you imagine 80% of the 22 million people infected right now are in hospitals nowadays. It's something that we cannot definitely handle. The other 20% divided between moderate, 15%, probably 60 to 75% out of these 15% end up in hospitals, and the severe cases are in the hospitals on either non-invasive mechanical ventilation or mechanical ventilation. We're going to talk about this as well. How do these patients present to the hospital or to a doctor's office? Most of them, they present usually with a dry cough, nagging cough that really goes on for days and days before the fever breaks. And the fever comes as second, close to 85%, but most of the patients, when they present to us, to clinic or to the hospitals, most of them, they really do not have fever. And there's a good percentage of people coming with fatigue, shortness of breath, dyspnea, even GI symptoms, nausea, vomiting, diarrhea, which is very unusual, but yes, they do present sometimes with as simple as vomiting. But I want to spend some time talking about the severity of COVID-19 and what do we mean by severity, because COVID-19 in the beginning, when we started dealing with this virus, it presented itself as the acute respiratory distress syndrome, or ARDS, because these patients will present suddenly very sick, very ill, septic, extremely hypoxic, and there's something we call the silent hypoxia. They are walking into hospitals or emergency department. You check their pulse oximetry and their oxygenation level is in the 80s or 70s, yet you look at them and they are not really short of breath. So really it puzzled us initially why this is happening. But as soon as these patients are really admitted to the hospital, they start crashing. They end up with multiple organ failure, or what you call MODS, multiple organ dysfunction syndrome. Pretty much every organ starts shutting down. And that's why in the beginning, we had extremely high mortality rate, whether in the US or in Europe. There's also something called the CRS syndrome, or the cytokine release syndrome, which is really comes slightly delayed, but once this cytokine is released in the body, it's a major inflammatory response syndrome, and it can cause, it's like adding fuel to the fire. Patients become really immunocompromised, their inflammatory cascade is all over the place, and they're really sick patients, and that's part of the high mortality rate initially. So this I touched on this previously when we talked about the majority of patients, definitely more than 30 to 65 present with mild symptoms, but close to 15% moderate to severe. This is initial data, but the most recent data confirmed that close to 80% of patients have mild symptoms, and the severe and extremely severe on mechanical ventilation can get up to 20%. Lab-wise, when we admit these patients, usually there is nothing really specific about them except inflammatory markers. Obviously, because it's viral, we don't see much of change in their WBC. They might be slightly leukopenic. But I want to spend some time talking here about the inflammatory markers, which are the CRP, the ferritin level. They started to climb little by little, and this is obviously because of the inflammatory response. The other thing is the D-dimer, which is also part of the inflammatory response, and we've seen this really in the thousands. And we're going to talk about this, how we approach the D-dimer and whether we should treat the patient for thromboembolic disease or not based on their symptoms. Next would be imaging. Because of most of these patients, especially lately, we know they are highly infective, and we don't want them to go from the emergency department or from the medical floor through the hallway down to the radiology department. So we've been trying to avoid CT scans as much as possible, but we do them if we have to later down in the disease process. So how would a chest X-ray look on a patient with mild case of COVID? As you see on this chest X-ray, we have very mild peripheral, some mild infiltrate, ground glass opacities, which is not very significant, but you can see it's kind of scattered across. When it's more advanced or moderate, you can definitely see all these fluffy infiltrate, scattered, diffuse, bilateral. It doesn't follow any anatomical structure. It's pretty much diffuse. And once patient is an advanced stage, obviously you don't need to be a pulmonologist or a radiologist or to tell that this is very significant and patient is already heading toward respiratory failure and soon will be intubated. So the lucky patients who will get to have a CT scan, this is how would an axial view look on a CT scan. So this is right side, this is left side, this is the front, and this is the back. So at this level, we see the right and left main bronchus. We see the heart sitting in the middle and the thoracic aorta. But the normal CT scan of the lung should look kind of this color here, dark gray to black. That's normal. But when you see something like this grayish, we call this ground glass opacities. It's diffuse in the upper lobe. I'm sorry, this is middle lobe here. This is in the lingula here. You can see it down here all over in the lower lobes. And we start to see a small degree of consolidation on this one. Definitely you see more consolidation or pneumonia-like picture on this one here, more toward the periphery on both right and the left side. And this is an overview of all the axial views, upper, middle, lower lobe. You have a lot of ground glass on this coronal section. It's a beautiful to see, but not to have. Definitely a lot of infiltrate, ground glass, and again, every segment of the lung is involved. So no wonder why these people will go into respiratory failure. The other modalities that we use for patients with, especially COVID, because we don't want them again to leave their room, isolation, to go to radiology, is we use what we call a point of care ultrasound. It's an ultrasound device we have in all our ICUs to look for, pretty much because now the evidence-based medicine we use for every procedure in the ICU, including to look for a pneumonia. So we look for something called B-line, and I'll show you a picture of this. So this is where the ultrasound device sits on the chest of the patient, and down at the bottom is where the lung is. So when you see these bands, like, you need to have 3 bands minimum to call this a B-line. basically what this represents, that's the congestions at the level of the pleura. You see this white line here going across? This is the pleura covering the lung. And when you have a pneumonia, congestions, or pulmonary edema, it will present itself as these lines called B line. The B lines are different from what we call A lines. The A lines are horizontal, B lines are vertical. The A lines talk about sliding of the lung. Usually we look at this for patients, let's say for a pneumothorax, but just to give you an idea here what this represents and why we do that. So definitely we can use an ultrasound device to look for such things, unless we want to do an X-ray. Next part would be testing. How are we been testing for these patients? In general, this is the preferred test, the nasopharyngeal swab or nasal swab PCR. Nowadays, you hear a lot of testing, could be the rapid testing, and actually last night the FDA approved the oral saliva for COVID-19. I do not have any exact data on this, but it was approved yesterday. But definitely for now, if you really want to test and rule in or rule out, this is what you need, the PCR, to look for SARS-CoV-2. And in the US, when we order a PCR for SARS-2, we also need to make sure we look for other respiratory pathogens. And I'm gonna jump slide forward and I'll come back to this. So when we order a PCR, the molecular diagnostic test, this is how it looks like. We look and make sure there is no other viruses included, like adenovirus, the non-COVID coronaviruses, 4 of them. We look for metapneumovirus, we look for rhinovirus, H. flu, parainfluenza, RSV, pertussis, and last but not least, the COVID. So this patient tested negative for all the other viruses except the COVID-19 positive. So this is how we test our patient. And by the way, since I'm on this slide, in the US so far, we have tested close to 75 million patients. Out of these 75 million, 9% tested positive, hence this number here. So pretty much 25% of the US population have been tested. And to go back to the slide here, we recommend not to do the sputum induction, because to induce a sputum, patient has to cough and has to spread the virus, and that's not something that we recommend. Again, we recommend against doing any bronchoscopy unless it's extremely important. The data on bronchoalveolar lavage for the pulmonologist is not very strong, and it's not something we recommend, so we try to shy away from it. That's why we avoid bronchoscopies. And unless it's necessary for patients who already been discharged from the hospital or have history of COPD, we always test them for COVID-19 before we send them for pulmonary function test or PFT. Once we have a diagnosis, what should we do? How are we going to treat these patients? If they are mild cases, definitely there's no reason to treat them with anything unless they are hypoxic or having more and more shortness of breath. They need to be admitted to the hospital. Then the treatment is completely different. But these patients, they need to be isolated. They need to have a mask, a droplet mask. We recommend them to have their own private room, private bathroom, to isolate themselves for 2 weeks. Unless they are in the hospital, obviously they are in individual rooms. We avoid non-essential visit. At this point, visitation in our hospital does not exist, unfortunately. Family members cannot visit their loved ones. They have to be isolated, complete isolation. But what we do, that's the best way, I think, for now, is we use iPad. They communicate with their loved one via FaceTime or different social media devices. Hand hygiene is extremely important, and contact precaution. At some point back in April and June, in our ICUs, we had all the pumps, all devices set outside the patient's room behind the doors, so the nurse can avoid frequent visits in and out to the patient's room, except the ventilator. They were stationed next to the patient, but everything else was pretty much outside. It's not an easy task, but we were able to manage it. When it comes to PPEs, it's very important how what we call donning and doffing of PPEs. Next slide, I will go over the sequence, how to start and how to finish, and then how to take the equipments off. Most of the time we use the N95 mask. We also have the North 55 mask, 5500, sorry. This is a very advanced device. It has filters on both sides. These filters are disposable. After a week to 2 weeks, usually we dispose them and replace them with new filters. And the exhaled air comes through this port down here. You can see me here wearing this mask. That's I was doing a bronchoscopy. I already took off my gown, but I still have my N5500 or North 5500 face shield with a cap on my head. So this is how we do the donning and doffing. This is what the chest and the CDC approved. First, hand hygiene, you wash your hands, then you gown up. The third part comes the mask. Once you have your N95 or the N5500 on, then you put the goggle or face shield. And last, we usually double gloves. We put 2 gloves on top of each other, and I'll explain why. Now, once we leave the patient's room, we do the what we call doffing sequence. First, we take off the first set of gloves, and then we take the gown off, the goggles off. Mask comes last before we remove the second set of gloves and wash our hands. This is the sequence for donning and doffing, and it's highly recommended to avoid co-infection or transporting the virus from one room to another. Also, general rules for treatment in general. Unless you suspect a secondary infection, we recommend no empiric antibiotics. We have not been using nebulizer therapy in any of our patients whatsoever. This is a way to spread the virus, so no nebulized therapy at all. Unless patient is on a ventilator, then we can use a closed circuit for these patients. Otherwise, we've been using MDIs, inhalers. Again, as the WHO and as you know, there is no reason not to use any NSAIDs, anti-inflammatory medications, as well as the ACE inhibitors 1 and ARBs. There's no reason not to use them. And I'm going to talk later about the thromboembolic prophylactic and treatment for these patients. Factors associated with worsening outcomes. In general, comorbidities are really what's really affecting these patients the most. Whether it's diabetes, cardiovascular diseases, obesity is a major concern here too, lung disease and hypertension. A lot of patients that we deal with already have baseline comorbidities, advanced age, and that put them at a much higher risk, 4 to 5 folds risk to acquire COVID and to, I'm sorry, not to acquire COVID, 4 to 5 fold the risk to die from the virus than someone with no comorbidities. And that's why part of the reason why we see less mortality in young population because of the comorbidities, obviously. Again, more comorbidities, the higher the risk to develop organ failure. We assess them through the SOFA score, and every patient come to our hospital get these baseline markers, D-dimer, LDH, ferritin, troponin, thrombocytopenia, platelets, and CBC with differential. How do we manage patient with hypoxia? If they are hypoxic, obviously we start with oxygen nasal cannula. If this is something that we think patient will be able to tolerate and keep their oxygen saturation to a minimum 92 to 94%. If not, then we move to the simple mask or non-rebreather mask. It's preferably not to use the NIPPV or the CPAP or BiPAP devices, again, because of the possibility to aerosol the virus. This is a major component here that I would like for you to be aware as well, what we call proning. Patients who is hypoxic, known to be COVID-19 positive, we highly encourage proning, meaning patient will sleep on their stomach down, face down, or at least on their side. You know, from the ARDS, that proning definitely improves the PF ratio and improve oxygenation. If patient needs to be intubated, then we highly recommend a video laryngoscopy. This way, we can get into the airway from first attempt and to avoid gagging and coughing and spreading of the virus more and more. And I mentioned already about the nebulizer, how we avoid them to prevent any nebulization of the particle of the virus. And last but not least is, again, it's part of the ARDS protocol. We use lung protective ventilation strategies, 6 ml per kg ideal body weight. This is based on the ARDS NEP protocol. So before we move into treatment, let me go over these 3 brief cases and we'll leave the good case for the end. So the first case, we have a 57-year-old male who's a non-smoker, never smoked, just known for history of hyperlipidemia. He presented to the emergency room complaining of mild headache with sore throat and fever. His symptoms were going on for 5 days initially. By the time he presented, he was having already dyspnea on exertion. On admission, he was hypoxic and he was started on oxygen 2-liter nasal cannula. He was admitted to a COVID unit, but not an ICU unit for this patient. He's an athlete, and I was kind of impressed me when he said, I used to do 60 push-ups, now I can do only 40, despite being hypoxic and sick anyway. So on admission, when he tested positive, he was started on Remdesivir IV, as well as Dexamethasone day 1, but the patient did extremely well, and on day 3 he was discharged home, and this is why we treated him only with 3 days of Remdesivir. Let me explain why we did this. First of all, I wish we were in Egypt, not in the USA, because we're having shortage with Remdesivir here, so definitely we've been trying to save every drug as much as possible to the sickest patients. So the CDC and FDA recommendation, if patients on Remdesivir and doing well needs to go home, the plan is to stop Remdesivir and not to finish the 5-day course. And that's why we treated him only for 3 days. But we started Dexamethasone, and then we switched him over to prednisone, 40 milligram, and he was treated for a total of 10 days. That's the reason we treated only for 3 days. The second patient, a 7-year-old, also presented with a cough. He was having really nagging cough for a few days, and then by the time he came to the ER, he was extremely short of breath and febrile. He was admitted to the hospital on day 5 after he was started on high-flow nasal cannula. The HFNC is high-flow nasal cannula. We can deliver up to 100 liters. He failed. Then on day 5, he was intubated. His PCR COVID-19 came positive before, and he was already started on IV Remdesivir. So he was treated with IV Remdesivir for 5 days with Dexa for a total of 10 days. He was extremely sick. He stayed intubated for 22 days. And because his condition was really critical, we ended up giving him convalescent plasma. It's an IV infusion. Luckily, he progressed, he improved, recovered, and he was discharged on oxygen nasal cannula 4 liters and physical therapy home. And the last patient, also a 7-year-old female non-smoker. She was admitted to the hospital. She came directly from the doctor's office to us, extremely hypoxic. She was started on 3 liters, and despite that, her oxygen is still 96%. She was admitted to the COVID unit, treated with remdesivir, dexamethasone for a total of 10 days, and she recovered, and she was discharged home also on PT. So these are positive cases, responded to treatment, and we're so happy to see them leaving the hospital and going home after they recovered. But as you know, a lot of patients did not make it. So now start the fun part. This is the part that I like, and I'm gonna spend some time talking about it. So I'm gonna mainly talk about, I'm gonna start with the trials, and these are all based on the trials that I'm sure you might be aware and familiar with them, and the treatment guidelines. So I'm gonna start first with the remdesivir trial. This study was initially sponsored by the NIH, the National Institute of Health in the United States. It's a multinational, randomized, double-blind, placebo-controlled trial. It was a multinational, as I said. Most of the centers were in the US, 45 out of 60. The rest were Mexico, Europe, and Asia. Patients were randomized 1-to-1 ratio between IV remdesivir, the RDV is abbreviation for remdesivir, and placebo for a total of 10 days. And the primary endpoint was clinical recovery. So this study actually started I believe in March, and on April 29th, because of the results was so positive, they released a preliminary report. That's why it's titled prelim report, because of the data that I'm gonna discuss in a bit. But briefly over the inclusion criteria, obviously patients have to have COVID-19 with pulmonary infiltrate or abnormal chest X-ray. They have to be hypoxic, and hypoxia was defined as oxygen level 94% or less on room air, or requiring supplemental oxygenation, mechanical ventilation, or ECMO, the extracorporeal membranous oxygenation. The exclusion criteria were either elevated liver enzymes, 5 times the upper limit of normal, or creatinine clearance with the GFR less than 30. These are the main exclusion criteria, and as well as pregnant and breastfeeding mothers. So let's go directly into the data, but first let me discuss a little bit the demographics here. So initially they had 1,059 patients included and randomized into the trial. As you see, most of them are North American, because 40% of the centers were in the US and Mexico, 25% or a little less in Europe and Asia. Also, most of the patients were white male, and for some reason, COVID-19 affects more male than female. We still have no explanation for that. But if you look at the age group, they had patients from 18 all the way up, but most of the patients, close to probably 80% here, older than 40 years of age. So good cohort, and again, mainly male. What's interesting in this study too, that the 664 patients were started on the treatment in the first 10 days after the symptoms started. But also, you see another probably 30% of the patients were treated after 10 days from their symptoms developed. So that's also significant too, because of the results were really intriguing. So as you see here on the rate ratio and the confidence interval here, both patients, whether they were treated in the first 10 days or 10 days after their symptoms developed, they still benefited from remdesivir, and they favored remdesivir compared to placebo. So this is significant, because even though we we want to treat the patient as soon as possible, as soon as their symptoms develop, yet even if patient was treated at a later phase, they still benefited from remdesivir. On this slide, this goes over the mainly the ordinal score. A majority of patients, close to 80%, were in score 4, 5, 6, and 7. And this is the strong data that comes out of this study here. Overall, when they compared remdesivir to placebo, definitely you can see here the number of patients who recovered from remdesivir compared to placebo, and the median time to recovery, 11 days versus 15 days, even though there is only 4-day difference between the two, but definitely it was very statistically significant. So this is powerful data. And after this study was published on the 29th of April, the following day, the FDA met and granted remdesivir the authorization. I'm going to talk about it briefly, but because of the primary investigators and the preliminary data was so strong, they decided to unblind the study because of the statistical significance of the study. So we know from this trial that remdesivir did reduce time to recovery. And definitely this was noticed in the group of patients who required supplemental oxygen. Let me go to the next slide. And this is released from the FDA on May the 1st, 2 days after the data was unblinded and the preliminary report was released, and FDA granted Gilead, the manufacturer of remdesivir, an emergency use authorization. And this basically was kind of a breakthrough for COVID. And since then, we've been using this treatment as, I would like to say standard of care at this point, but this is the only drug that we've been using, and we've seen, I would say, positive and good results out of it too. If you look at the NIH website, specifically at the clinicaltrial.gov, you see that remdesivir is still going multiple active studies. We have 4 completed, and out of 24, 20 still actively recruiting at different levels, different studies. So there's more data to come, and we're going to discuss one more trial here. So in general, we know that at this point, there is no single drug approved for treatment for COVID-19, but remdesivir is the first FDA authorization or authorized drug to be used for patients with COVID-19. Definitely we need more data for the future, but the data that we have as of now is strong, positive, and pointing to the right direction, and it has a trend. And in clinical medicine and ICU care, trend for us is really what is the most important part. When you see the trend heading into one direction, that tells you a lot, and I think this has a good potential. Recently, also at the 23rd International AIDS Conference, the Gilead released this new data as well. It's a comparative analysis of phase 3, and also looked at the retrospective cohort of patients. In this analysis, they looked at 2 endpoints. One is recovery. When they looked at the recovery of patients treated with remdesivir compared to standard of care, 74.4, close to, let's say 74% recovered versus 59% by day 14. Also, when it comes to mortality, there were only 7.6 mortality compared to 12.5 in the standard of care group by day 14. But what's really important here to me is the odds ratio. Look at the odds ratio, it's 0.38 with a statistically significant p-value. And this is why we see a 62% reduction in the mortality rate should have it somewhere in here. I think it's hidden behind. I'm sorry, it's hidden behind the Dr. Gehan on the right side hand of my screen. So yes, there is a 62% reduction in the risk of mortality compared with standard of care. Why? Because of the odds ratio, obviously. So yes, there is valuable additional information from this retrospective cohort and the comparative analysis, and this definitely points to benefit of remdesivir over standard of care. Also, they analyzed what we call the compassionate program, and specifically pediatric population, as well as pregnant and postpartum patients. And there's a significant improvement in here as well. Noted 83% of the pediatric population and 92% of pregnant or postpartum women recovered by day 28. And by recovered, they meant, or they defined it as, a patient who left the hospital or discharged from the hospital on no supplemental oxygen. That's how they defined recovery, and that's significant too. So stay tuned for the global open label phase 2 and 3 trial, which is going to be released, I hope, very soon. Here they are looking at the safety and efficacy and tolerability of remdesivir in the pediatric population. I personally do not treat pediatrics or peds, but the youngest person I've treated for COVID is 16 years old. We still admitted him to the medical ward for adult, but this is something that I'm looking forward to see what is gonna show. Are we gonna see the same results, or hopefully something better in the younger population? So there is a prospective clinical trials that I think it's something to look forward and wait for the data. Next, we're going to talk about different type of drugs. These are the immunomodulator or IL-6 inhibitors. So this study, they looked at the tocilizumab in patients with severe COVID-19 as a retrospective cohort study. This was published in June in the Lancet of Rheumatology, June of this year, obviously. So it was a retrospective observational cohort study with patients with COVID-19. And this came out of Italy, 2 different cities, from Modena and in Bologna, between February and April of 2020. And here they looked at the composite of either mechanical ventilation or death. These were the outcome they were looking at. So if you look at this data here, the tocilizumab was given to patients via 2 forms, either subcutaneous or intravenous, compared to a placebo. So obviously this patient on high oxygen flow, looking at the PF ratio here, you see that in general, the patients who are treated with tocilizumab were much sicker. Their PF ratio 169 compared to 277. And a lot of them were on mechanical ventilation, 18%. Definitely, there is no statistical difference between the tocilizumab and the standard of care. And the death rate, they claim that in the tocilizumab was 7% and 20% in the standard of care. So based on this study, they claim that tocilizumab did improve mortality, but the result turned out to be completely different than that. So we'll talk about this. So based on this study, there is a couple limitations here, a very important limitation. Number one, this study was not randomized, and it was an open label, so the medical staff were all aware who's getting what. And the other issue was the rate of secondary infection. As you know, tocilizumab is an IL-6 inhibitor, so a lot of patients develop significant percentage of infection, 14% in the tocilizumab compared to 4% in placebo. So that was definitely a significant side effect. So the recommendation was to go and do more studies for this drug with randomized studies. So that's what they did. And if you look at the clinicaltrials.gov, also you see tocilizumab is running actually 9 different studies right now, different studies, different schemes. But I'm going to focus on this trial here, and this is what we call the COVACTA. The COVACTA trial was sponsored by La Roche, the manufacturer of tocilizumab, looking at the safety and efficacy of this drug in a cohort of 450 patients. Not bad, good group. So what they did, they gave the experimental drug as an IV this time, not subcutaneous, 8 milligram per kg. And if the patient was critical and very sick, they allowed an additional dose. That's in the experimental arm. And on the other hand, the placebo arm, they gave them placebo, obviously. So the inclusion criteria, they were looking for patients who have hypoxia, meaning oxygen saturation 93% or less, with a PF ratio less than 300. This is how we define ARDS. Plus changing on the X-ray or CT scan consistent with COVID-19. Unfortunately, this study didn't show anything significant. Actually, it was not statistically significant at all, and it did not meet the primary endpoint, meaning it did not show any improvement in mortality, and also it did not show any improvement in ventilator-free days, so it did not meet also the secondary endpoint. So obviously, based on the COVACTA, there is no benefit from using tocilizumab, and currently we are not using this drug in the US. So let's go from a negative study to a very positive study here. This is the recovery trial. And the recovery trial came out of the UK when they looked at dexamethasone in hospitalized patients with COVID-19. And this was released on July the 17th. It hit the news, made big headlines because it's a very powerful study and showed very significant results. So let me tell you, as an intensivist working in the ICU and reading literature on ICU patients, I've never yet to see a clinical trial, ICU patients with this much cohort. We're talking 6,425 patients combined. This is unheard of in the ICU. Probably this is the only thing that's came good out of this COVID-19 this year. So it allowed us to look at a large group of patients in ICUs, severely hypoxic on mechanical ventilation or non-invasive ventilation. So in one arm, dexamethasone, 2,100 patients, and the usual care, 4,300 patients, almost a little over double the number. And the rest of the demographics here are very similar when it comes to age. Median age was 59, 66, and 65, distributed all over, predominantly male, and median number of days since hospitalization, 2 days, 1 to 5 days. But majority of patients were either on oxygen, 61% versus 60 in the usual care, and the invasive mechanical ventilation, 15 versus 16%. So very similar data and very large cohort. So let's look at also at the comorbidities here. As you see, we have pretty much very similar comorbidities from diabetes, heart, lung, infectious, immunocompromised patients. So they had a very broad spectrum of comorbidities, and 88 versus 89% positive COVID-19. So very nice broad spectrum of patients. Now we'll go and look at the analysis and the rate ratio here. So in the invasive mechanical ventilation arm, 29% of patients on dexamethasone, that's it, I'm sorry, 29% recovery versus the 41%. So definitely the patient who came off the mechanical ventilation, I'm sorry, I misspoke here. Mechanical ventilation was required only in 29% versus 41% in the usual care. So this tells you right away that there is definitely a significant statistical and clinical improvement. And you can see that mechanical ventilation favored the dexamethasone arm. Same for oxygen. So every patient who required supplemental oxygenation and to keep oxygen saturation greater than 94%, only 23% versus 26%. So definitely it also favored the dexamethasone arm. So dexamethasone or the corticosteroids showed significant effect on patients who are on supplemental oxygen or definitely on mechanical ventilation. However, it did not show any effect on patients who did not require supplemental oxygen. And as you can see it here, it did cross the median. And overall, this is a breakthrough for a study with corticosteroids, specifically dexamethasone, to show significant impact on patients who require supplemental oxygen or mechanical ventilation with significant improvement. So here we have a 30% reduction in mechanical ventilation, and on the supplemental oxygen, close to 20% reduction. So that will take us to the this summary of recovery trial. Again, as I mentioned here, it did reduce the mortality by 30% on the mechanical ventilation arm and by 20% in patients requiring supplemental oxygen. It did not affect the duration of hospitalization in the hospital as much as other studies, but definitely the mortality was significant in the dexamethasone. And this is, again, a breakthrough with a number needed to treat 1 in 8. So you treat 8 patients to save 1 patient. That's very, very powerful. Next trial, which is the Remdacta. And this is an interesting study, and let me explain. We know that tocilizumab failed its trial. It didn't show any effect or improvement on mortality, nor on recovery. So because it is an IL-6 inhibitor, it works on the inflammatory cascade. It has a potential. I think that's what made La Roche approach Gilead, and it has a potential to see what would a combination would do. So this is a phase 3 randomized, double-blind, multi-center study combining in one arm remdesivir with tocilizumab, and in the second arm, I'm going to call it the standard of care, remdesivir with placebo. And again, this is sponsored by La Roche with collaboration with Gilead, the manufacturer of remdesivir. So the study is just started not long time ago, a little over a month now, and it's ongoing. In the experimental arm, we have remdesivir plus tocilizumab, and remdesivir will be given as an injection excuse me, with a loading dose on day 1, followed by 100 milligram from day 2 to day 10, and tocilizumab as 1 single injection on day 1 as well. In the standard of care arm, remdesivir plus placebo, also loading dose plus 100 milligram day 2 to 10. So inclusion criteria for Remdacta, looking at patients with any changes on chest X-ray consistent with COVID plus COVID-19 positive test, and the supplemental oxygenation to keep saturation greater than 93%. Exclusion criteria, obviously, we do not want anyone with active infection or suspected infection. Why? Because IL-6 can suppress the immune system and cause more infection. We know that already caused 14% over placebo, and we don't want that. Definitely anyone who might be allergic to any monoclonal antibodies, or someone on immunosuppressant or active cancer. So what should we expect from Remdacta? That's kind of a million-dollar question here, but we know tocilizumab did not improve survival. So now we're looking at alternative. Is it capable, once it's combined with remdesivir, to affect the patient in a way where it can suppress the inflammatory response? So probably it can potentiate the effect of remdesivir, possibly. It's something to wait and see. It is logical to combine these two drugs. I don't think there's something or anything wrong about it, because there is the potential. The potential is there, and when we talk about the potential here, is specifically about the window of when to start the medication, when the inflammatory cascade starts to affect the patient. This is a very gray area where it's going to be extremely hard really to tell when the cytokine might be released, unless you'll be checking IL-6 on a regular basis, and I don't think anyone wants to do that. But there is, again, as I said, there is a window, there is a possibility, and I think I wouldn't be surprised if we see some positive results. So again, I don't want to guess or predict, but I would like to wait and see what the results will be. And the last part of this section is the convalescent plasma, or CP. In the US, the FDA approved convalescent plasma as emergency investigation new drug. This was approved on March 4th, and multiple centers, including our institution, we are actually using convalescent plasma, part of a trial. The primary investigator is Mayo Clinic in Minneapolis, and we are part of this trial. We've been given convalescent plasma as adjunctive therapy to patients either with very severe advanced hypoxia or who are not improving between 10 to 14 days from the initiation of remdesivir and dexamethasone. So again, it's we're still waiting on more data to be released. We need more trials and ongoing randomized trials as well. Who's eligible for convalescent plasma? Anyone older than 18 with positive COVID-19, an acute care facility. Obviously, it has to be an ICU, not a medical ward. And we always obtain a consent from the patient's family, because this is experimental drug, even though it's approved by FDA as such, but we still take consent from patient's family. And this is for patients with severe or life-threatening COVID-19 who presents with or having persistent dyspnea, tachypnea more than 30 times a minute, hypoxia with a PF ratio less than 300, and obviously infiltrate on their chest X-ray, and persistent over the last 24 to 48 hours before the initiation of the infusion. Again, convalescent plasma is given as an infusion. And for life-threatening, for persistent respiratory failure, septic shock, or MODS, meaning multi-organ dysfunction syndrome. So finishing with the trials, let's talk about the treatment. I'm going to talk first about how in the US we are treating our patient with COVID-19, which is considered a first-line therapy, and then what other recommendation by ATS, ACCP, NIH, and FDA. So this slide summarizes basically what we're doing in the US, how are we treating our patient, and with what. Every patient who qualifies based on their chest X-ray, and obviously have to be COVID-19 positive with hypoxia, because remember, remdesivir is indicated for patients who are hypoxic, less than 94% solid room air. They automatically qualify for this drug. It's given as an injection, 200 milligram on day 1, and then followed by 100 milligram a day for 4 days. And the pediatric population is a little different formula to calculate the dose. The second drug is dexamethasone. Again, as I mentioned, based on the randomized control trial from the UK. Also, it's given for a total of 10 days, whether IV or PO. So at some point, we had a small shortage, so we were using solomedrol or hydrocortisone, but patients who are improving and going to the medical floor, still in isolation, we convert them to prednisone PO 40 milligram daily. And last but not least, the third drug comes as the convalescent plasma. And again, it's given as a 1 unit infusion, usually over 2 hours for patients who after 10 to 14 days do not show any signs of improvement. Then we give them the plasma. We've been actually giving it close to a week. If I want to say a mean day, I would say 7 days. We're trying not to wait too long for the immunoglobulin really to work and give the effect. Next, I want to briefly talk about some recommendation. Again, according to the NIH and CDC, hydrochloroquine and or hydroxychloroquine, we recommend against them, and we are not using them actually. Same for a combination of hydroxychloroquine with azithromycin. It's not recommended to use as a combination because of the side effect, cardiac side effects mainly. The antiretroviral or HIV medications, lopinavir or ritonavir, again, no data to support the use, so not recommended. The JAK or tyrosine kinase inhibitors, no recommendation. We recommend against them. IL-6, we do not have enough data to support that. This is interleukin-1, not interleukin-6. The interferon, again, no recommendation. We recommend against them. So what else we use for these patients as an adjunctive therapy? So we treat every patient with COVID-19, especially on mechanical ventilation, as ARDS. So that's why we use the conservative fluid resuscitation management. So we avoid aggressive hydration, basically. Next, I mentioned this in the beginning, we use MDIs, we do not use a nebulizer, and antibiotic routine empiric treatment is not recommended unless there is active infection or suspected bacterial infection. When it comes to thromboembolic medications and COVID-19, again, it's a significant inflammatory response. The body is trying to fight this virus, so there's an immediate release of the coagulation cascade. So that will put the patient at a higher risk for thromboembolic event. So every patient with COVID in our hospital is being treated with prophylactic dose with unfractionated, with low molecular weight heparin or fondaparinux. We do check D-dimer a little more frequently, definitely on admission, and then every 2 to 3 days, we check the trend. As long as we see the trend going down, there is no reason to treat the patient with therapeutic dose of anticoagulation. And this is, again, recommended by CHEST, or the American College of Chest Physicians, thromboprophylaxis or a prophylactic dose for COVID-19, either with low molecular weight heparin, fondaparinux. No reason to give them high dose heparin or therapeutic dose unless there is a PE, DVT, or you suspect high risk. And this is from the Surviving Sepsis campaign. 2 points I want to focus on here are the high flow nasal cannula. We try as much as possible to avoid mechanical ventilation and intubation. So we put them on the high flow nasal cannula, and we we avoid any non-invasive PPV. And the second point is, I touched on this earlier, is the prone position. This is where we really see significant improvement in oxygenation. And again, proning has no effect on mortality, has no effect on the virus load or shedding. It affects only the PF ratio, the oxygenation. So as soon as you can put the patient in a prone position, complete prone position, meaning face down, laying down on their stomach, or if they cannot for other reason, you can put them on their side. And our protocol is 18 hours of proning on mechanical ventilation. Non-intubated patients, we ask them as frequently as possible and as tolerated. How we control the virus, again, as of now, besides medication, I think by far the best effective treatment would remain the social distancing, hand washing and hand hygiene, and wearing facial masks. By far, I think this is what's really gonna contain this virus and prevent it from spreading and taking control over us. Okay, now we're coming toward the end. Let me take a sip of water. All right, so this is an interesting case. 55-year-old male, is known for history of hypertension, atrial fibrillation, AFib, and benign prostatic hypertrophy. He presented initially with shortness of breath and low-grade fever. According to the patient, his symptoms started 3 days prior to presentation. He developed initially shortness of breath at rest, and then he was extremely short of breath walking short distance. He was febrile, 101 degrees Fahrenheit, which is equivalent to 38.3 Celsius. As his symptoms progressed, he developed some mild chills, but cough was, in his case, was productive of yellow, pinkish color secretion. He was also complaining of nausea, myalgia, and he had loss of taste, which is anosmia. He didn't have any other GI symptoms or rhinorrhea. On admission, the patient was exposed to his son and his friend who tested positive previously. So when his symptoms presented, he went to the urgent care and he had a COVID test done the day before he came to the hospital. So that's why his test results were still pending. But due to persistent symptoms, he called his primary care physician, who advised him to come to the hospital. So he came to the ER and he was admitted on June the 30th. On admission, he had a chest x-ray. He was taken directly to isolation because of his presentation and his story, that he was exposed to his son who tested positive, and because he was hypoxic, obviously that was another red flag. The same day we tested him for COVID, he came positive. His CRP was very high. That's the C-reactive protein was greater than 400. Our norm is less than 8. WC were elevated. Remember, he had a cough with sputum production with 28,000. It started at 17.5, increased to 28,800 with leukopenia. BNP was very elevated. Ferritin was kind of on the edge, and definitely elevated LDH. Because he was hypoxic, and because he tested positive for COVID-19, and because of the changes on the chest X-ray I'm going to show you, he was started on remdesivir on the 1st of July with dexamethasone, and because of his cough and sputum production with leukocytosis, we had to give him broad-spectrum antibiotics with racefin and azithromycin, pending the cultures. And for his AFib, he was treated with heart rate control and anticoagulant. So this is his chest X-ray on June the 30th. This is how he presented. Definitely, if you remember the previous X-ray I showed you, it looks like very advanced, middle and lower lobe on both sides, very affected. You can hardly see the diaphragm on both sides. And significant, definitely consolidation at the bases. I don't see the part of the diaphragm here and ground glass opacities. And this is July the 1st. Yes, this is July 1st. You think this is improved, but this is actually the same, if not worse. Why I say that? Because this is what we call over-penetrated X-ray. You see this oval-shaped structure here? These are the spinous processes on the vertebral body. You cannot see them here as here. That means there is excessive X-ray radiation, or what you call over-penetration. That's why it looks like there is less ground glass and more air, but not really. This is pretty much the same. So chest X-ray from the first definitely did not change. Sorry. Okay. The ABG from the first patient was very hypoxic. As you see, his PO2 was 52 on 100% of IO2. His oxygenation worsened. He was more and more short of breath. So he ended up intubated on July 1st because of severe ARDS, and because of the PF ratio is 52 over 100, definitely is less than 100. So that's considered severe ARDS. So he was intubated on the first. As you see, we have endotracheal tube on the first. There is some air moving slightly better because of the ventilation and the positive pressure ventilation, some improvement. And over the course of the treatment, he stayed on the ventilator for 15 days. And because we could not wean him off, and he failed to wean off mechanical ventilation, he ended up with a with a tracheostomy. So here's the tracheostomy tube in here, and still we see ground glass infiltrate bilateral, but slightly better than the admission. And on the 18th, once he was already 2 weeks after the initial presentation, and he's already on trach, we sent him for a CT scan. You can still see the trach here going through the neck into the trachea. So again, this is the right side, this is left side, front and back. So these are the APCs of both lung, right and left. See the degree of inflammation and the consolidation, infiltrate, very diffuse, very significant. You can see these lines here, we call them air bronchograms. And he had a very small Pneumo Mediastinum. I want you to know too that lately, not lately, but in general, we've noticed that a lot of patients with COVID-19, they have, or they are more susceptible or more prone to develop Pneumo Mediastinum. What it means, air that leaks around the lung that surrounds the heart. In his case, he had mild Pneumo Mediastinum. And at the bottom of his lungs, definitely you see the degree of damage caused by the virus. So on the 19th, things didn't get any better. He ended up developing aspiration pneumonia. He was getting tube feeding. So because of the fever, we sent the sputum for culture, turned out to be positive for Pseudomonas, and we treated him with cefepime for 7 days. Again, on the 22nd, he, because of fever persisted, the blood culture grew fungus, and it was positive for C. albicans, so he was treated with fluconazole. He continued to improve despite all these major events happening to him. And on the 5th of August, 2 weeks ago, he was decannulated, the trach was removed. And on the 10th of August, he was discharged to rehab. And that's pretty significant. And this is the 26th of July. You see the trach. And this is on August 5th, the day the trach was removed. You see the chest X-ray, almost complete resolution of the infiltrate that you see here, almost gone. And definitely the left lung significantly better. So he was discharged on the 10th after he was diagnosed with COVID, multilobar pneumonia. I forgot to mention that he had DVT in the right lower extremity, even though he was taking Eliquis at home for AFib. Aspiration pneumonitis, fungemia with C. albicans, septic shock, anemia, and he was discharged on physical therapy. So now we're moving into the last part of my presentation, and let's look at this beautiful map. It's lighting up like Christmas tree. As you see, every part of the world is coming up as positive. So right now, as of yesterday, the count, we're 22,233,000 plus worldwide, with 783,000 plus deaths. That is definitely how you define a pandemic, global with significant death rate. When it comes to the US, if you split the US in the middle, definitely you see the eastern part of the US, mainly the major cities on the coast. This is New York, Washington, Boston, DC, Philadelphia, Atlanta, and Florida down here, where the heavy load of cases. On the West Coast, we see some in Seattle and Washington State. We see California also coming up, and Texas probably in the eastern part of the health. In the US right now, we have 5.5 million cases, again, as of yesterday, with 172,000 cases. And if you look at the bottom of my screen in the right lower corner, you see this graph over started from March. We see the spike, and then it trended down. And again, mid-June, we started to see another spike that went all the way up, and it reached peak July the 14th, I believe. We had like, I can't remember the number, but definitely after this peak, we are trending down, and that's very significant. Sorry. So in Florida specifically, in the beginning, when you heard about the New York cases, we really were not affected at all up until mid-June. That's when the numbers started to spike. And on July the 12th, in Florida, we hit our peak, 15,300 cases in one day in Florida, mainly out of Miami area and Dade County. This is Miami-Dade County here. I live in Orlando, or Orange County. We are here in the middle, and we have close to 34,000 cases. So as you look at this trend from July 12th until August the 12th, definitely you see a downtrend, significant major drop. That's what we really want, and this is the trend we want to follow, and hopefully every country will follow this trend. In my institution, we are a group of 5 hospitals, close to 2,500 beds. And at the beginning of the pandemic, on the 22nd, we started with 10 cases. By the way, the orange line is the total number of cases per day. And the purple line is representation on mechanical ventilation. So at the beginning of the pandemic, you see a very small number of patients that has stayed low all the way until mid-June, and then started to peak. So we went from 40 to 433 cases on July 18th. And this is 1 week at a time. And from mid-July until now, you see the down slope, and this mirror definitely the numbers in Florida as well. So we went from 433 to 133. This is 60% drop, or 2/3 as well. If we look at Egypt, you have currently 96,753 cases with 5,184 deaths. But that's something that I still cannot understand, why China has only 89 cases, 89,000 cases. Either the air they breathe has antiviral in it, or remdesivir, you know, or they are not reporting their cases. There must be something strange here, but definitely this number do not make any sense whatsoever. And that would lead me to my, toward the end, and talk about the myth and of this pandemic. Is it a myth or a fact that there is a second wave? I've been asked this question many times, and I can say up until now, we have seen in many parts of the world cases spiking or declining in some places. But the pandemic is still evolving at many. There is no, even though we see some slowing down, but overall the numbers are still spiking, but they are not spiking countrywide. They are spiking from one city to another. You would see small cities or towns here and there with a small spike, but it's not like the entire country is showing this spike or increased in number. This outbreak is really strange. This novel virus, again, as I said in the beginning, is not behaving in a standard way. It's very erratic, very irregular, very I'm not sure how to explain this, why the widespread is not happening all over, at least in the same country. Why we see it, the one spike in small city and next day it disappear and spikes in another place. As communities, we started to open up cities, schools, universities, businesses. This might be part of the reason why the spikes are happening not homogeneously, but historically, if we go back to 1918, the Spanish flu, or 2009, during the SARS, they both happened in the spring, and again they spiked in the fall. So I do believe what we're seeing right now is nothing but regular behavior of a virus, as well as I have no doubt in my mind we are still in phase 1. We have not seen wave 2. You cannot have phase 2 unless you finish phase 1. What we are seeing right now are spikes and outbreaks, and this is not the wave or second wave. That's what my understanding and how I would interpret this response or the breakout of the virus. So no, we are not in wave 2. We are still battling with phase 1. You see numbers are spiking again in multiple parts of the world, Europe, Middle East, Africa, South America also, numbers are coming back. But I do believe together what we need to do is work more on the conventional standard therapy as hand hygiene, hand washing, face mask, and social distancing, what really could help us and take us a long way. And the bottom of my screen would represent some facts or myths. You can read on your own, but I think this will take me toward the end of my presentation. My references based on the CDC and the FDA, CHEST, ATS, IDSA, or the Infectious Diseases Society of America, and of course the NIH guidelines for for treatment. They've been guiding us throughout this pandemic and over the last 6-7 months to fight and battle this virus. And I want to thank you all for your time. I enjoyed talking with you, and I'll be taking more questions toward the end. Thank you.
Thank you, Professor Ziad. And let us welcome Professor Gehan with Phases of Egyptian Protocol Against COVID-19. Welcome, Dr. Gehan.
Welcome, Dr. Rahab. First of all, I'm trying to share my screen. Okay. Is it okay?
Let us share it because it's still not shared. Still we see only slides.
باينة كده؟
Okay, doctor, you can press Control F5 to be online presentation.
Control F1.
F5, yes.
Okay, I'm pressing.
Yes. Then,
Okay.
A small window will appear to you. Online presentation, so you have to click OK.
ما طلعتش عندي. السكرين باينة عندك كده؟
It takes time. No, it's not shared. هي دلوقتي مش shared إنها presentation. هي shared slide separate. هي بس عايزين show يعني نعملها show presentation. So Control F5 مع بعض again. دكتور معلش it takes يعني.
Control F1. Yes.
F5. F5.
F5. Okay. Control F5.
Just seconds كده وهتبتدي presentation to show.
Okay. مفيش ظهرت عندك؟
لا هي لسه مش ظاهرة. طب ممكن دكتور مصباح
شير من عندك
ممكن دكتور مصباح تشير with us.
اوكي.
presentation for Dr. Gehan.
اوكي ماشي.
اوكي لغايه لما دكتور مصباح يحضر البرزنتيشن اسمحوا لي طبعا ان انا الاول اشكر شركه ايفا على الدعوه اللطيفه للمشاركه. بشكر استاذي الاستاذ دكتور اشرف حاتم هو استاذي طبعا وسعيده بالمقدمه اللي قالها. يسعدني ويشرفني ان انا ابقى مع بروفيسور زياد مطر وحضرتك حقيقه واجهه مشرفه لينا كلنا وسعيده ان انا ابقى معاك في ميتنج واحد. يمكن النهارده انا هتكلم باختصار شويه. انا هركز على الفيزز بتاعت الايجيبشن بروتوكول او اللي عملناها احنا في اللجنه في الايجيبشن بروتوكول اجينست كوفيد. هي ظهرت عندكم ولا لسه؟
لا هو دكتور احمد مصباح انت معانا؟
دقيقة واحدة بس، ثانية واحدة عشان بعمل لها داونلود بس.
اوكي. طيب ممكن نبتدي على ما تبتدي اول سلايد. هو طبعا اول حاله كوفيد ظهرت عندنا في مصر كانت تقريبا في 14 فبراير 2020. اتكونت اللجنه العلميه
انا اسف معلش
لمكافحه الكورونا في مارس. اعمل ايه؟
في الشير بتاع السكرين بس عشان اعمل سكرين شير
اوكي.
وهيك اول ما حضرتك توزي نيكست
اوكي اتفضل.
نيكست السلايد على طول.
اوكي. اوكي.
عندكم زهرة؟
انا بالنسبه لي شايفاها دكتور مصباح.
تمام اتفضل يا دكتور.
نيكست. دكتور مصباح نيكست.
اوكي. عملت نيكست.
انا مش ظاهره عندي بقى نيكست اللي انت عملتها. ايوه اوكي. اول بروتوكول اتعمل عندنا اتعمل باللجنه العلميه. الحقيقه اللجنه العلميه كونتها وزاره الصحه بقرار وزاري مشكله من اعضاء هيئه التدريس من جامعات مصريه مختلفه، ومعاهم استشاريين في مجالات الخاصه بالكوفيد، التشست والانتنسيف كير والتروبيكال ميديسن والتخصص الامراض المعديه infectious disease. وابتدينا حطينا اول بروتوكول. الحقيقه كان اول يعني فكره ان احنا هنيجي نحط البروتوكول، يمكن احنا هنحط ايه الانتي فايرال او هنستعمل ايه انتي فايرال. يمكن دكتور زياد استعرض لنا العديد من الانتي فايرالز اللي استعملوها. احنا كان عندنا بالنسبه لنا ما ابتدينا في الشهر 3 ما كانش لسه طبعا في كلام عن الريمديسيفير، لسه الفابي برافير ما كانش لسه برضو في حاجه واضحه عليه. كان شويه كلام على الهيدروكسيكلوروكين، على الانترفيرون، على الريبافيرين، كانت كلها ترايلز. طبعا لغايه دلوقتي يعني العمليه كلها مجرد ترايلز، بنشوف which has better outcome عن التاني. ساعه ما اخترنا في البروتوكول فكرنا ان احنا نختار الدواء اللي يبقى افيلبل وفي نفس الوقت يبقى اقدر اوفره ويبقى متاح عندي. فكان الحقيقه الاختيار على هذا الاساس لحالات الكوفيد ان احنا هنستعمل الهيدروكسي كلوروكين. الهيدروكسي كلوروكين الحقيقه كان سبب اختياره اولا ان كانت معظم النتائج، وخصوصا احنا كانت سبقتنا ساعتها في الوقت دوت، يمكن لسه ما كانش ظهرت حالات كتيره في امريكا، لكن كانت سبقتنا الصين وايطاليا. وكانت هو استعمل في البروتوكول الصيني واستعمل في البروتوكول الايطالي، وكانت نتائجه الى حد ما معقوله او comparable with other antiviral. فتم اختيار الهيدروكسي كلوروكين. فاول بروتوكول اتحط ده كان في شهر 3. تم الاتفاق على ان ما دام احنا عندنا الاعداد لسه قليله، لسه في الاول، ونسب الاصابه مش عاليه قوي، واحنا عندنا مستشفيات العزل متاحه وجاهزه وكنا مجهزه لاستقبال المرضى، فكانت الفكره في ان احنا نقدر نعزل كل الحالات. فالحقيقه احنا عملنا يمكن حاجه مختلفه عن بقيه البروتوكولات اللي اتطبقت في دول العالم. زي ما كان بيقول دكتور زياد، هم في امريكا كانت الحاله ما دام مش سيمتوماتايزنج مش نيدنج هوسبيتال ادميشن ما بيحجزوهاش في المستشفى. لا احنا في العكس، احنا اما ابتدينا اول بروتوكول في اول 3 كان اي حاله بوزيتيف حتى لو اسيمتوماتيك كنا بنعزلها في المستشفى. الكونسبت كان ان انا بتجنب انها تبقى سورس اوف انفكشن. ما دام انا عندي افيلبل بيدز، عندي الرفاهيه ان انا عندي اماكن متاحه في المستشفيات ان انا اعزل عيانين، فانا بكده ممكن اقلل الريت بتاع الانفكشن. وعلى هذا الاساس ابتدى الكونسبت ان انا اعمل عزل حتى للحالات الاسيمتوماتيك، يعني الكونتاكت كيسز اللي كانوا بوزيتيف بي سي ار فور كوفيد ولكنهم asymptomatic patients without any symptoms كان بيتم عزلهم لغايه لما البي سي ار بتاعهم يدينا 2 ريدنجز consecutive ورا بعض نيجاتيف. الكونسبت ده فضل موجود لغايه لما مستشفيات العزل ابتدت تتملي او الاعداد ابتدت تزيد فيها. فاحنا في اول بروتوكول فعلا انا سامعه صوت وش، مش عارفه من عندكم ولا من عندي. كنا بنعتمد على ان اي حاله في البروتوكول الاولاني ان اي حاله suspicious، وهنا كنا بنعتمد على suspicious كيس في التشخيص ان هو يكون عنده symptoms one of the symptoms سواء with or without fever cough shortness of breath whatever السيمتومز بتاعت الكوفيد اللي كانت معروفه ساعتها، معاه لاب findings suspicious زي lymphopenia with or without leukopenia، معاه CT findings suggestive of COVID. العيان دوت انا هعتبره suspicious دوت كجروب كلينيكال. في جروب تاني اللي هو كان جاي من اي epidemiological كيس اللي هو جاي من اي كونتري او من اي اريا كانت ظهرت فيها حالات بوزيتيف فور كوفيد، فكنا برضه بيتعمل له بي سي ار. الحاله الثالثه اي عيان باكيوت ريسبيراتوري النس without obvious cause بيدخل المستشفى هتعامل معاه لانه suspicious of COVID. كانت الحالات دي بيتعمل لها اسسمنت، يتعمل لها الاذر انفستيجيشنز المحتاجه لو كان لسه ما تعملوش الراديولوجي اللاب، وكنا بنقسم الحالات ان هو على طول لو هو لسه سسبيشس ولسه ما عملتلوش البي سي ار ومش متاكده ان هو كوفيد، يبقى في الحالات لو هو ستيبل اقدر اعمل له هوم ايزوليشن وكنت في بعض الاوقات كمان لما كان بيبقى عندي متاح كنت ساعات بعمل فاسيلتي ايزوليشن، استخدمنا دور الحضانات، دور الرعايه لو الحاله ما عندهاش الابيليتي او الفاسيلتي الكفايه في البيت فور هوم ايزوليشن، مش متاح، لان ده ممكن يبقى مشكله في معظم بيوتنا المصريه. ويتم العزل لغايه لما تطلع نتيجه البي سي ار. لو طلع البي سي ار بوزيتيف على طول بيتحول لديزاينيتد هوسبيتال فور ايزوليشن. لو الحاله طلعت نيجاتيف وهو سسبيشس especially by radiology or by يعني كلينيكال بيكتشر مع السي بي سي، العيان ده كنا بنعيد له البي سي ار تاني لو طلعت اول مره نيجاتيف، عشان طبعا السنسيتيفيتي بتاعت البي سي ار ما كانتش عاليه قوي، فكنا بنعيد له البي سي ار تاني، ولو طلع بوزيتيف بيتحول على طول على ديزاينيتد هوسبيتال. في المستشفى كان بيتم علاج الحالات على انها اولا لو حاله مايلد او مودريت ماشي، وطبعا تقسيمه المايلد والمودريت والسيفير والكريتيكال يقل طبعا كلكم عارفينها. المايلد زي ما اتفقنا كلنا هو اللي عنده السيمبتومز بتاعت الكوفيد without radiological finding. المودريت كيس هو عنده radiological finding او بيكتشر اوف نيمونيا لكن ستيبل ما هواش هايبوكسيك. لو العيان ديفلوبت هايبوكسيا او الاكسجين ساتوريشن بتاعه على الروم اير قل عن 93 او الريسبيراتوري ريت زاد عن 30 او ابتدى يحصل بروجريشن للراديولوجي بتاعه اكتر من 50% في وقت سريع، ده هعتبره على طول سيفير كيس. لو العيان ديفلوب اي اورجان فيلير وخصوصا ريسبيراتوري فيلير او جاله تشوك او حصل في اي اورجان فيلير او اي انديكيشن للاي سي يو ادميشن، ده هعتبره كريتيكالي ال بيشنت. وكنا بنقسم العيانين، لو العيان مايلد او مودريت كيس على طول هياخد التريتمنت بتاعه. التريتمنت بتاعه هيبقى لا اما طبعا الريستريكتيف انفكشن كنترول ميجرز، بياخد سبورتيف ميجرز، بياخد انتي بايوتيك او سيمتوماتيك تريتمنت. الانتي فايرال اللي كنا بنديه في الوقت دوت لكل الحالات سواء مايلد او مودريت وحتى سيفير كيسز كان هو الهيدروكسي كلوروكين. كنا بندي الهيدروكسي كلوروكين بلودنج دوز 400 مللي جرام مرتين في اول يوم، وبعد كده 200 مللي جرام توايس ديلي لغايه لما نكمل الكورس، وكان الكورس من 7 ل 10 ايام. في الفتره دي احنا اول ما ابتدت الحالات واول ما ابتدى الحالات كنا لسه في فتره السيزون بتاع H1N1، وعلى هذا الاساس زودنا في البروتوكول بتاعنا كنا بندي الاوسيلتامافير مع الهيدروكسي كلوروكين عشان نكفر لو في كو انفكشن مع H1N1 في الحالات. طبعا العيانين كان بيعمل لهم اسسمنت، كانوا في بعض الحالات يمكن، وده يمكن حاجه من الحاجات اللي كنا واضحين فيها من الاول، هي الكونترا انديكيشنز لاستعمال الهيدروكسي كلوروكين. بمعنى احنا كنا من الاول بريسايز ليفر كونديشن الانزيم البيز لاين، لو العيان عنده كرونيك كاردياك ديزيز او وخصوصا لو الريزميك، لو العيان مثلا عنده جي 6 بي دي ديفيشنسي، لو عنده اورفي، عنده لو عنده اي تراكيش كنا في العيان وكان ديلي up to 10 نفس الانسولين هو ده كان الانتي فايرال الحقيقه اللي كان متاح عندنا في هذا الوقت، او اللي افيلبل يفرق من بعد كده والعيان او سيفير والعيان اتحسن بنعمل له بي سي ار، وبيتعاد البي سي ار تاني بعد 48 ساعه. لو لقى مرتين نيجاتيف بي سي ار بينهم 48 ساعه كنا ساعتها بنديشارج بيشنت عشان يكمل فور هوم ايزوليشن فور انذر 14 days after discharge. كنا بنكمل في اول العيان كمان بعد ما يخرج نكمل، لان احنا كنا لسه خايفين فكنا بنريكومند ان حتى العيان لما يخرج بعد المخروج واخد 2 سامبلز نيجاتيف ان هو يبقى او اللي ما كانش او او الاكسجين. كانت الريكومنديشن لينا في الاول ان احنا في الميكانيكال دي اقيد النون انفيزيف فنتريشن قلب هي ممكن اوبستراكشن في المكان.
دكتور انا اسف ان انا هقطع حضرتك، بس الصوت اختفى عمال يقطع بقاله فتره.
يمكن احنا تقول احنا مش عندنا، احنا ممكن نضغط بقيتنا.
دكتور جيهان، هو الصوت او في مشكله في الانترنت كونكشن عند حضرتك غالبا؟
صوت حضرتك مش واضح خالص يا دكتور.
ممكن دكتور جيهان تقفل الكاميرا لو ممكن تكمل فعلا فويس. دكتور جيهان مش معانا حاليا.
سامعيني كده؟
هستاذن حضرتك تقفلي الكاميرا يا دكتور. then الكونكشن
كده
الصوت بيقطع خالص.
انتوا سامعيني؟
سامعين كده.
اوكي، انا مش عارفه بقى سمعتوا الجزء الاخير ولا لا؟
الجزء الاخير كله يا دكتور
سامع.
حضرتك انهي سلايد برضو عشان نوقف عليها؟
ايه؟
حضرتك عايزين نقف عند انهي سلايد؟
احنا لسه في الاي سي يو مانجمنت. الاي سي يو مانجمنت دي بتاعت بروتوكول مارس.
تمام، اللي هي عليها دلوقتي.
ايوه اللي احنا عليها دي.
تمام، اتفضل يا دكتور.
زي ما قلت ان احنا كان لسه الكلام على ان الايرلي ميكانيكال فنتيليشن هو الريكومندد، وان احنا افويد النون انفيزيف عشان ممكن يبقى سورس اوف انفكشن. وعلى هذا الاساس كنا بنريكومند ان احنا نعمل شورت ترايل النون انفيزيف. لو العيان مش ريسبوندنج ساعتها هنشفت للميكانيكال فنتيليشن. وكانت الكرايتيريا اوف ميكانيكال فنتيليشن زي كرايتيريا اوف ميكانيكال فنتيليشنز العاديه. لو العيان ابتدى يبقى هايبوكسيك اقل من 90، لو في بروجريسيف هايبركابنيا، لو البي اتش ابتدت تنزل عن 7.3. وكنا بنحط البارامترز بتاعت الميكانيكال فنتيليشن، بنكونسيدر الفوليوم كنترولد مود، وبنحطه في الكونسرفاتيف مودز بتاعت الميكانيكال فنتيليشن. طبعا كان الفولو اب ديلي بالاكس راي وباللاب للانفلاماتوري ماركرز. از ريجارد المانجمنت كنا بنكونسيدر برضو زي ما انتم عارفين الهيدروكسي كلوروكين، زي ما قلنا كان ده كورنر ستون في المانجمنت عندنا لان ما كانش متاح عندنا غيره. لكن هنا بقى في العيانين الكريتيكالي ال كنا بنقدر نزود الازيثرومايسين. وطبعا كان في كلام على ان الازيثرومايسين ان كومباينيشن مع الهيدروكسي كلوروكين ليه سينرجستيك افكتس، وكانت مشكلته دايما انه هو ممكن يعمل تاكي اريثميا. فهنا هو ده اللي خلانا سيلكتد الازيثرومايسين ان كومباينيشن مع الهيدروكسي كلوروكين في عيانين الكريتيكال ال، ان احنا قلنا هم كده كده هيبقوا على مونيتور في الرعايه وهيبقوا اندر مونيتور، فهنقدر نتديتكت لو ديفلوبد اني ايرلي اريثميا ممكن تحصل. الحقيقه البروتوكول بتاعنا برضو في الاي سي يو مانجمنت كان من الايرلي بروتوكولز اللي استخدموا الاسترويدز. يعني دكتور زياد كلمنا عن الريكفري ستادي، ودي كانت لسه منشوره قريب يمكن بعد البروتوكول بتاعنا بفتره طويله. احنا الحقيقه من اول شهر 3 وكان في الاسترويدز موجوده في البروتوكول المصري، برغم ان كان في ريكومنديشنز من الاجينست يوز اوف ستيرويدز طالعه من الدبليو اتش او وقالت ان هو ملوش رول وبالعكس ممكن يبقى له هازارس افكت. لكن احنا استعملنا الهيدروكورتيزون، واستعملنا 2 فورمز اوف ستيرويدز في البروتوكول. الفورم الاولانيه هي الهيدروكورتيزون، قلنا لو العيان كان هايبوتنسيف او هيمودايناميكال انستيبل ونقدر نديله 50 مللي جرام كل 6 ساعات. الفورم الثانيه كانت السوليوميدرول، ودي استعملناها لو العيان كان بيرزيستنت هايبوكسيك او نوت ريسبوندنج او ابتدى يديفلوب اي ار دي اس. يبقى هو الحل هنا ان احنا ندي ميثايل بريدنيزولون، وكنا بندي بدوز 2 مللي جرام بير كيلو جرام بير داي، بندي من 3 ل 5 ايام. وقلنا لو العيان بعد 48 ل 72 ساعه ما ابتداش يتحسن كنا بنبتدي نستارت التوسيلوزيماب او الانتي انترلوكين 6 علشان تاوفركم السيتوكاين ستورم. فالحقيقه يعني انا سعيده ان احنا في البروتوكول المصري من اول شهر 3 يعني لسه الاستاديز بتتكلم عن الريكفري، بتتكلم عن الاسترويدز وبيتكلموا عن نتائج التوسيلوزيماب. احنا اوريدي في البروتوكول المصري كانت الادويه دي محطوطه برغم يمكن امكانياتنا في بقيه الادويه ما كانتش موجوده، لكن اكشوالي الاسترويدز والتوسيلوزيماب موجودين في البروتوكول بتاعنا من شهر 3. نضيف على كده كمان ان احنا كنا حاطين الانتي كواجيليشن كجزء من الباندل بتاع الميكانيكال فنتيليشن والاي سي يو مانجمنت في البروتوكول بتاعنا من شهر 3. يعني كل عيانينا اللي كانوا في الاي سي يو كانوا بياخدوا انتي كواجيليشن. اي نعم ما كناش بندي للعيانين قبل الاي سي يو، لكن العيان الكريتيكال ال كانوا كلهم بياخدوا انتي كواجيليشن ان ثيرابيوتيك دوز. ده از ريجارد الاي سي يو مانجمنت. طبعا العيان لو انديكيتد زي ما قلنا الميكانيكال فنتيليشن كان بيتحط على الميكانيكال فنتيليشن وبن ايفالويت الموقف. لو فضل ستيبل بنكمل على الميكانيكال فنتيليشن از لونج از ان انا ما عنديش اوبشنز ثانيه. العيان اتحسن طبعا بنوين وبنكمل مانجمنت عادي. لو لا قدر العيان ما اتحسنش بيبقى عندنا الاوبشن بتاع الاكمو في الحاله. واحنا كان الاكمو برده محطوط كجزء من البروتوكول من اول شهر مارس، بس الحقيقه الحالات كانت قليله. يعني احنا الحالات اللي اتعمل عليها اكمو من اول كوفيد لغايه دلوقتي يمكن حالات تعد على اصابع اليد يعني زي ما بيقولوا، والحقيقه الاوت كام والريزلت بتاعتهم ما كانتش حلوه لغايه دلوقتي. نيكست بليز دكتور مصباح. زي ما قلنا العيان هيكمل لو احتاج الاكمو كان موجود من البروتوكول في شهر 3، او العيان هيكيب على ميكانيكال فنتيليشن لغايه لما نقدر نعمل له ويننج. وبرده بعد الويننج احنا بنري اسس العيان لغايه لما ناخد 2 نيجاتيف سامبلز عشان يبقى ديشارج. فانا كان كورنر ستون او شرط من شروط الديشارج من الهوسبيتال هو 2 سامبلز نيجاتيف فور بي سي من البي سي ار with 48 hours apart. نيكست دكتور مصباح. البروتوكول اللي بعد كده ده كان بروتوكول مارس، استمرينا بيه لغايه ابريل. التغيير كان في ابريل على طول. طبعا الميزه بتاعت الكوفيد ان هي ايه ابديتنج فيري رابيدلي، واحنا كنا بنحاول نكوب معاها، فكنا بنحاول نابديت. احنا فعلا في ابريل على طول الشهر اللي بعديها عملنا ابديت للبروتوكول. يمكن كان في بوينتس مش كتيره، لكن اي ثينك ان هي كانت فيري سيجنيفيكانت وبتقول ان احنا قد ايه في البروتوكول المصري برضو الحمد لله كنا ابديتنج مع كل الداتا. اول حاجه ان احنا ابتدينا نستعمل الايزوليشن فاسيلتي للحالات المايل كيس. ابتدت الحالات تزيد في ابريل، فاحنا ابتدينا قلنا لا مش كل الحالات هقدر اعزلها في المستشفى، فبدانا نوفر الايزوليشن فاسيلتيز. ودي كانت عباره عن فنادق مقفوله، دور رعايه ايتام، مدن جامعيه للطلبه. كانت اماكن بيتم يعني التحقق من امكانياتها ان هي تبقى محققه فيها العزل والامكانيات الواضحه للعزل، وكان ليها اشراف طبي خاص في كل مبنى منهم. وكان العيان عندنا لما يبقى مايل كيس، الاسيمتوماتيك كيس كانت بتروح على الايزوليشن فاسيلتي على طول في شهر ابريل. العيان عنده مايل كيس كنا برضو في الاول بندخله مستشفى تؤسس اول 5 ايام، لان احنا عندنا نسبه مثلا اب تو 10% من الحالات ممكن تبقى بعد كده تقلب لمودريت او سيفير. فاحنا كنا بنأسس العيان اول 5 ايام ونطمن ان الامور ماشيه ستيبل ومفيش كومبليكيشنز، وبننقل العيان يكمل التريتمنت بتاعه لغايه لما يقلب نيجاتيف البي سي ار في الايزوليشن فاسيلتيز. التشينجز الثانيه اللي حصلت واللي كانت برضو اي ثينك ان هي مهمه، ان احنا ابتدينا نوسع استخدام الازيثرومايسين. لما لقينا نتائجه ان كومباينيشن مع هيدروكسيكلوروكين في الحالات كريتيكالي كويسه، قلنا طيب ما انا عياني السيفير ده اوريدي برضه عيان هايبوكسيك فهو اوريدي على مونيتور، فانا طيب ما انا استعمل الازيثرومايسين مع هيدروكسيكلوروكين واحط العيان على مونيتور وفولو اب، وفعلا كان بيجيب نتائج ككومباينيشن انتي فايرال فيري افكتيف. الميزه الثانيه ان احنا ابتدينا نشفت الانتي كواجيوليشن. كان ساعتها بقى ابتدت الكلام على حالات السادن ديث بوست كوفيد، على حالات ان في ثرومبوامبوليك مانيفستيشنز، كان لسه كلام لكن ما فيش ستاديز واضحه في الامور في الموضوع ده. وابتدينا فعلا احنا خطوه استباقيه ان احنا وسعنا، قلنا طب احنا بندي ثيرابيوتيك دوز للعيان كريتيكال، احنا العيان وهو سيفير هبتدي له بروفيلاكتيك انتي كواجيوليشن عشان ابروتكت اجينست ان يحصل ثرومبوامبوليك مانيفستيشن. الحاجه كمان اللي زودناها ان احنا عملنا شيفت البرومبوزيشن. دكتور زياد يمكن كلمنا باستفاضه وبشرح جميل الحقيقه عن البرومبوزيشن واهميته ازاي بيحسن الفي كيو ماتشنج بتاع العيان دوت. احنا كنا في الاول في بروتوكول 3 محطوط بروم بوزيشن مع العيانين اللي على ميكانيكال فنتيليشن بس، بنحط بروم بوزيشن، كنا كاتبين كونسيدر بروم بوزيشن لما تقدر. طبعا مش كل السناتر ولا كل الناس كانت تريند كفايه على البروم بوزيشن، فابتدينا نعمل لهم تريننج هاو تو يوز او هاو تو ابلاي بروم بوزيشن مع العيانين وهاو تو جيت بيست بنفيتس منه. البروم بوزيشن ابتدينا نشفت فيه، بدل ما كنا بنستعمله في العيانين كريتيكال لا، ابتدينا العيانين حتى السيفير كيسز اللي على اكسجين، سواء بقى الاكسجين ده نون ريبريزنج ماسك، هاي فلو نيزال كانيولا، بيستعمل اكسجين ثيرابي عادي، حتى لو على النون انفيسيف هجربه، بحاول اجربه بالبروم بوزيشن. نيكست دكتور مصباح. زي ما انتم شايفين ده يعني صوره للالجوريزم بتاع البروتوكول بتاع شهر 4. الكولوم اللي على اليمين اللي انتم شايفينه احنا هنا حاطين فيه ان على اليوم الخامس في اخره من تحت، لو العيان المايل، لو العيان ستابلايز ما عنديش فيه اي كومبليكيشن، اقدر انقله للايزوليشن فاسيلتي. ابتديت في السيفير كيسز اللي هو السكند كولوم فروم ليفت، ان انا حطيت فيه الازيثرومايسين اقدر ازوده، زودت فيه البروم بوزيشننج بصوره واضحه ان انا اقدر استعمله وان العيان مش على ميكانيكال فنتيليشن، والانتي كواجيليشن بروفيلاكتيك انتي كواجيليشن اتحط ككورنر ستون في المانجمنت بتاعي. اول ما العيان يبتدي يبقى هايبوكسيك هديله انتي كواجيليشن بدري علشان تو افويد الكومبليكيشنز اللي ممكن تحصل. البروتوكول دوت فضل مغطي من ابريل لغايه تقريبا اخر مايو لما ظهر البروتوكول بتاع شهر مايو، وكان اخر ابديت لغايه دلوقتي. بليز دكتور مصباح نقلب. نيكست. في ماي بروتوكول بقى كنا خلاص الاعداد بدات تزيد فعلا، ابتدينا بقى نوسع الهوم ايزوليشن، بقينا نعالج المايلد كيسز ات هوم. يعني احنا الاول كان حتى الاسيمتوماتيك في المستشفى، في ابريل قلنا لا المايلد هندخله 5 ايام نطمن عليه بس ونظبط الدنيا ونكمل في الايزوليشن فاسيلتي بعد كده. يعني حتى مش هنكمله في الهوم، لا هيبقى في ايزوليشن فاسيلتي وفي ميديكال سوبرفيجن عليه. في البروتوكول في 5 كانت الاعداد ابتدت تزيد، وابتدينا نطبق الهوم تريتمنت للعيانين والهوم ايزوليشن للمايلد كيس، وحطينا شروط للهوم ايزوليشن. مش اي عيان، حتى المايلد كيس مش كل مايلد كيس تقدر تتعالج في البيت. يعني المايلد كيس علشان يتعالج في البيت لازم يكون سنه اقل من 60 سنه، لازم تكون حرارته اقل من 38، الساتوريشن بتاعه اكتر من 92 على روم اير او 92 او اكتر، الهارت ريت بتاعه اقل من 110، ريسبيراتوري ريت اقل من 25، الان ال ريشيو بتاعته اقل من 3.1، ان هو يكون عنده كنترول كوموربيديتي. لو هو ان كنترولد مثلا دايابيتس، ان كنترولد كرونيك رينال ديزيز وات ايفر، يبقى العيان ده على طول فور هوسبيتال ايزوليشن او ايزوليشن فاسيلتي. ولو بريجننت فيميل او عيان مالجننت او بياخد اميونو سبريسيف دراجز، او البادي ماس اندكس، حتى الماربت اوبيستي اعتبرناها وان اوف كوموربيديتيز وممكن تبقى سيريس وكانت المورتاليتي مرتبطه معاها، فعملنا بادي ماس اندكس اكتر من 40، ده انديكيشن انه ما ياخدش الهوم ايزوليشن. كانت الحالات ديت لا اما بيبقى عندي اوبزرفيشن ليها في الايزوليشن فاسيلتي او الهيلث كير فاسيلتيز ان انا بتابعها وهي مايلد كيسز، او ان انا لو هي ستيبل وفولفيلنج الكرايتيريا للهوم ايزوليشن بقدر اعزلها في البيت. وابتدى صرف الميديكيشن من المستشفيات وزاره الصحه لاي حاله سسبيشس. هنا ابتدينا حتى ما نستناش لما نعمل بي سي ار فور دايجنوز، يعني الاول كنا بنشترط ان احنا العين نثبت انه بوزيتيف عشان ندي له علاج. ابتدينا في بروتوكول مي ان احنا نبتدي لا ده احنا اون سسبيشس، لان احنا لقينا على الفتره من اول ما ابتدينا البروتوكول من اول 3 لغايه مايو انا ما عنديش ذات سايد افكتس او سايد كومبليكيشن من الهيدروكسي كلوروكين اللي تخوفني من استعماله. بالعكس انا على الناحيه الثانيه في عيانين زي روماتويد ارثرايتس او العيانين الكولاجين ديزيز بيستعملوا هيدروكسي كلوروكين للسنين، ما فيش مشكله ما دام انا فولفيلنج الكرايتيريا وبتجنب الكونترا انديكيشنز الاستخدام. وعلى هذا الاساس كنا بنصرف الهوم تريتمنت عباره عن الهيدروكسي كلوروكين مع سبورتيف تريتمنت ان ذا فورم اوف فيتامين سي، زنك، اسيستين الى اخره، الحاجات اللي انتم عارفينها. طبعا العيان كان بيكمل العلاج بتاعه لغايه لما الامور بتتحسن، وكان بيتعمل لهم فولو اب سواء في الهوم كان بيتم متابعتهم تليفونيا او في تيم اللي هم الطب الوقائي كان بيتابع حالات الهوم ايزوليشن. الحالات اللي في الهيلث كير فاسيلتي كانت اندر دايركت سوبرفيجن من ميديكال تيم موجود في الايزوليشن فاسيلتيز دي، وبنكمل معاهم بالعلاج. نيكست دكتور مصباح. الحالات بقى المودريت ديت اللي كنا هنحجزها في المستشفى او هتبقى هوسبيتالايز وهتاخد العلاج في البيت. وده كان عندنا 2 اوبشنز ليها، اما ان انا ادي الهيدروكسيكلوروكين، وادينا اوبشن تاني لو العيان كونترا انديكيتد في الهيدروكسيكلوروكين ان انا اجرب ان انا ادي كومباينيشن بتاع لوبينافير وتينوفير، وده كان اوريدي موجود زي ما قلنا من الاول من شهر مارس في الحالات اللي ما كانتش تنطبق عليها شروط استخدام الهيدروكسيكلوروكين، ان انا استعمل ممكن معاه كمان ازود الريبافيرين. والحقيقه هنا برضو حصل التطور اللي احنا قلناه، ان انا ابتديت بقى في البروتوكول بتاع شهر 5 ان انا ادي بروفيلاكتيك انتي كواجوليشن من اول المودريت كيس. يعني خدوا بالكم احنا في ابريل شفتنا من سيفير من كريتيكال ال تو سيفير كيس. هنا في ماي احنا شفتنا استعملنا حتى المودريت كيس، اي عيان عنده نيمونيك باتشز في السي تي كنا بندي على طول بروفيلاكتيك انتي بايوتيك، الا لو الدي دايمر بتاعه لقيناه 1 أو اكتر على طول كنا بنبتدي ثيرابيوتيك انتي كواجوليشن. يعني ساعتها بقى في ماي ده كانت ابتدت تطلع الاستادي بتاعت البوست مورتم بتاعت ايطالي، واللي كانت ابتدت تحذر من الثرومبوامبوليك كومبليكيشنز اللي لقوها بوست مورتم ليه في عيانين من عيانين الكوفيد. فابتدينا ندي بروفيلاكتيك انتي بايوتيك. الميزه كمان او الحاجه اللي زودناها هنا ان احنا ابتدينا قلنا نستعمل الاويك برومبوزيشن. الاويك برومبوزيشن نستعملها في المودريت كيسز ماشي، وما استعملناه مع سيفير كيسز لو هم اويك او هايبوكسيك كانت الدنيا النتائج بتحسن. لو العيان المودريت ده ابتدى يتيريوريت بمعنى ان الديسني ابتدت تزيد او السي تي فن المودريت كيس، احنا هنا ابتدينا في شهر 3 الاسترويد مع كريتيكال البيشن، في ابريل زودنا للسيفير كيسز لو العيان ديتيريوريتد. جينا في ماي قلنا العيان المودريت اول ما يبتدي ديتيريوريت انا مش هستناه لما يبقى هايبوكسيك ويبقى سيفير كيس، لا مجرد ديتيريوريت كلينيكال او راديولوجيكال بنستارت الاسترويدز ليه على طول، وده الحقيقه جاب اوتكم كويس قوي في نتائج العيان. نيكست دكتور مصباح. طيب السيفير والكريتيكالي ال بيشنتس عملنا فيهم ايه؟ طبعا احنا قلنا تعريف السيفير والكريتيكالي ال، بس احنا عملنا لهم حاجه سميناها كده السرفايفل تشين. عملناها زي تشين كده زي ما انتم شايفينها، هي عباره ان احنا العيان ده كان بياخد الانتي فايرال دراج، واحنا هنتكلم بالتفصيل عن انتي فايرال للعيانين السيفير وكريتيكالي ال اللي موجوده في البروتوكول. قلنا العيانين سيفير وكريتيكالي ال دول هنستارت ايرلي ستيرويدز زي ما قلنا من 1 ل 2 مللي جرام بير كيلو جرام بير داي خلاص. ولو العيان على اليوم 48 ل 72 ساعه ما تحسنش بديله التيسيلوزوماب. كنا في الاول يمكن بنشترط ان انا اعمل انترلوكين 6 ليفل او ان انا اعمل الاتش سكور واجيب سكور اكتر من 169، لا احنا في بروتوكول مايو قلنا لا، وانس ان العيان مش ريسبوندنج على الاسترويدز انا هستارت على طول التيسيلوزوماب، لان احنا لقينا ان العيان اللي بياخد برضه التيسيلوزوماب ايرلي نتائجه كانت احسن، فبنعمل ايرلي بلوك للسيتوكاين ستور. العينين دول طبعا كنا بنكونسيدر فيهم الانتي كواجيليشن، والعينين السيفير زي ما اتفقنا والكريتيكال اللي بندي ثيرابيوتيك انتي كواجيليشن، وخصوصا لو دي دايما عندهم اكتر من واحد. الاويك برومبوزيشن زي ما قلنا لو العيان اويك او حتى ميكانيكال فنتيليشن كنا بنحطه على البرومبوزيشن، كانت الحقيقه من اكتر الحاجات اللي بتجيب نتائج العيانين بالذات السيفير والكريتيكال ال. حط العيان على هاي فلو نيزل كانيولا، كنا يعني دايما الاي سي يو تيم في المستشفيات عندنا يقول لك حط العيان على هاي فلو نيزل كانيولا، اديله انتي كواجيليشن فول انتي كواجيليشن، حط العيان على برومبوزيشن يو ويل جيت ذا بيست ريزلتس. طبعا الاوكسجين ثيرابي زي ما اتفقنا هنفاضل ما بين الاوكسجين ثيرابي سواء الهاي فلو نيزل كانيولا لو افيلبل، لانها طبعا للاسف عندنا ما بتبقاش افيلبل في كل السنترز، او الاوكسجين نون بريثنج ماسك او وات ايفر الاوكسجين ثيرابي اللي هنستعمله، او نون انفيزيف ولو العيان احتاج ميكانيكال فنتيليشن. الحقيقه النقطه بتاعت الميكانيكال فنتيليشن هنا اسمحوا لي يعني اعلق عليها. احنا يمكن كان في الاول في شهر 3 كان كل الكلام ان ايرلي ميكانيكال فنتيليشن بيسيف البيشنتس لايف، لكن الحقيقه بعد كده لقينا الاوتكم، والحقيقه مش عندنا احنا بس اي ثينك على مستوى العالم كله، الاوتكم مع العيانين اللي بيتحط على ميكانيكال فنتيليشن كان فيري باد، يعني المورتاليتي بتوصل ل 77 او 80% في بعض السناتر. يمكن احنا برضو عندنا بنتكلم في رينج قريب لكده في بعض السناتر، لكن الاوتكم في الميكانيكال فنتيليشن كان وحش، فده اللي خلانا يمكن نريكونسيدر بعد كده ونقول للعيان لا جرب النون انفيزيف، جرب الهاي فلو نيزل كانيولا مع البرومبوزيشن وهتجيب نتائج احسن. نيكست دكتور مصباح. الانتي فايرال بقى في السيفير والكريتيكال ال، احنا هنا كان لسه لما حطينا البروتوكول اتحط 29/5 اظن، نزل 29/5، كانش لسه الريمديسيفير افيلبل ان ايجيبت، فاحنا حطينا برضو، رجعنا الجولد ستاندرد بتاعنا الهيدروكسيكلوروكين اللي هو اللي افيلبل عندنا، هو اللي جاب نتائج. يمكن في السيفيرو كريتيكال ما كانتش نتائجه الحقيقه افكتيف، وكان في الوقت ده الحقيقه ما فيش انتي فايرال جاب نتيجه. برضه بستعمله ممكن ان كومباينيشن مع الازيثرومايسين او الدوكساسايكلين. كانت ابتدت بقى تطلع ستاتس ساعتها على ان الدوكساسايكلين ممكن كان بيوز از ريبليسمنت للازيثرومايسين، وليه يمكن ليس اريثموجينيك افكت عنه. وكان الكومباينيشن الثاني او الاوبشن الثاني ان انا برضو زي ما قلنا لو العيان كونتر انديكيتد فيه الهيدروكسيكلوروكين هنزود اللوبينافير روتينافير كومباينيشن زي ما قلنا. وهنا قلنا هنعمل حاجه اسمها تريبل ثيرابي، لوبينافير روتينافير كومباينيشن مع ريبافيرين مع الانترفيرون. بس الحقيقه كان يعني لما جينا بقى في التطبيق كان عندنا مشكله ان الانترفيرون ريليتد للانست اوف تريتمنت، يعني هو كانتي فايرال لازم نستعمله ايرلي. فمعظم حالات السيفيرو كريتيكال ال بيجي لك بعد اكتر من 7 ايام، او ممكن يبقى بقى له اكتر من 7 ايام من الستارتنج سيمبتومز او داي زيرو عنده. فيمكن الاوتكم في العينين دولت ما كانش بيبقى كويس قوي، فده خلانا نبتدي نكونسيدر. كان الريمديزيفير ساعتها لسه مش افيلبل في الماركت عندنا، فساعتها حطيناه قلنا اف افيلبل او وانس افيلبل هيبقى الريمديزيفير مستعمل كانتي فايرال في البروتوكول. البروتوكول بتاع شهر مايو ده هو نفس البروتوكول اللي ماشي لغايه دلوقتي، لسه ما عملناش اي ابديتس ثانيه في البروتوكول. وده بسبب ان احنا لغايه دلوقتي يمكن ما يعني مستنيين نتائج. احنا يمكن اللجنه من الاول ما ابتدت هي معتمده على الايفيدنس بيس داتا مينلي من الاوتكم بتاعت نتائجنا. فاحنا فعلا في نتائج على ميني انتي فايروس شغاله دلوقتي، احنا مستنيين بس الداتا بتاعتها الفاينل عشان لو هنعمل موديفيكيشن او ابديت للبروتوكول يبقى ساعتها اكوردنجلي النتائج بتاعتنا الخاصه. طبعا زي ما اتفقنا العيانين لو محتاجين النون انفيزيف او الميكانيكال فنتيليشن اكوردنج للكونديشن بالاسسمنت العادي بتاعهم. لو العيان هيحتاج انفيزيف ميكانيكال فنتيليشن يبقى طبعا زي ما دكتور زياد قال ان احنا لازم ندي نبقى التيم لابس فول بي بي ايز. طبعا كان في انستراكشنز، كان في محاضرات بتتعمل لكل الدكاتره. كل تيم رايح مستشفى العزل كان قبل مستشفى العزل قبل ما يروح كنا بنعمل له كلجنه بيتعمل له محاضرات تدريب اولا على البروتوكول، نشرح له البروتوكول ونفهمه الستيب وايز مانجمنت للعيانين. كنا بنفهمه كان بيبقى في محاضرات على انفكشن كنترول وازاي يتعامل مع البيشنت وهاو تو افويد تو جيت انفكشن. كل ده كان بيتعمل كتريننج كورس للدكاتره قبل ما يدخلوا مستشفيات العزل. وكان التيم طبعا بيتغير زي ما حضراتكم عارفين، كل 14 يوم كان بيدخل تيم ويخرج تيم، يدخل تيم مكانه بيسلم جوه مستشفيات العزل. نيكست يا دكتور مصباح. ثانك يو. ده ملخص البروتوكول لغايه مايو. احنا لغايه دلوقتي ما عندناش لسه ابديت، زي ما قلنا مستنيين نتائج الريزلتس بتاعتنا احنا طبعا، ومع الاطلاع على نتائج بقيه الناس هنشوف ان كنا هنحتاج نعدل البروتوكول ولا هنعمل ايه لو حصلت لا قدر الله الويف الثانيه اللي بيتكلموا عليها. شكرا.
Thank you so much Professor جيهان. دلوقتي كان دكتور ميشيل حابب يقدم كلمة لحضرتك والبروفيسور زياد مطر. دكتور ميشيل.
مساء الخير عليكم جميعا. الأول we would like as EVA Pharma to thank our panelists Professor Ashraf Hatem, Professor Gehan Elasal, and our showstopper for tonight, Professor Ziad Matar. Thank you so much for this very, very effective hands-on clinical experience that was shared effectively between the United States and Egypt. Thank you very much, Professor Gehan, for this very smart and very nice presentation about our own data coming from our hospitals in Egypt, deep from the heart of the Ministry of Health. It's really very enlightening to find that we are truly following evidence-based medicine, and we are looking forward to the updates in our Egyptian guidelines. We cannot end this session before telling and wishing Dr. Ziad and our hearts go out to Lebanon, especially the great city of Beirut. All our heartfelt support. Allow me to speak on behalf of EVA Pharma, of our panelists, and of our all Egyptians. وهتكلم بالعربي هنا واستعير من الشاعر الكبير نزار قباني بيت مهم جدا قاله في القصيدة العظيمة بتاعته يا بيروت يا ست الدنيا، لما قال لها قومي من تحت الردم كزهرة لوز في نيسان، قومي من حزنك قومي. All the best and our heartfelt support and our prayers to the brave and the wonderful city of Beirut وللبنان كله في المحنة وإن شاء الله تعدي. Thank you very much for this wonderful presentation, all our panelists, and hope you've enjoyed this presentation and this brief differences and many times similarities between the Egyptian and the United States or the American way of dealing with COVID-19. Thank you very much, and back again to you, Rehab.
Thank you, Dr. Michel Amir, the medical manager for EVA Pharma. And now we can move to your question and answers, all HCPs. And we'd love to hear from you all questions. Actually, we got a lot of questions. Will be managed by the medical advisor, Dr. Ahmed Misbah. Welcome, Dr. Ahmed.
Thank you, Dr. Hab. We have received above 100 questions. We will start with some questions as long as time allows us. I know Dr. Ziad and Dr. Gehan must be tired from this rich data and rich presentation. So I'll start by Dr. Ziad and ask him, there is a question, is it correct to start antiviral treatment for patients presented after 10 days of starting symptoms with severe presentation?
Thank you, Dr. Gehan, for the great presentation and for you to go over the protocols. Very labor-intense work. Dr. Michel Amir, أنا بشكرك على السبورت. Really, what we went through in Lebanon, especially in Beirut, was unheard and unthinkable. I want to thank you and thank the Egyptian government who already sent their support already, and even the Egyptian people in Lebanon, they came to Beirut downtown and offered their help and support, so we greatly appreciate it. To answer the question, Dr. Ahmed, yes, based on the data that I already presented, it's never too late to start remdesivir. If you can start it in the first 10 days from the onset of symptoms, it's better. Otherwise, you're still gonna get the benefit whether you treat it for 5 or 10 days with remdesivir.
Thank you, Dr. Ziad. My next question is to Professor Gehan. This question that some recovered cases may die from lung embolism several months from recovery. Is it true, and how to minimize this mortality rate?
الحقيقه في الاول انا ما اقدرش احكم several months لان احنا اوريدي المرض عندنا من شهر زي ما اتفقنا فبراير، واكشولي كل الحالات اللي حصل لها sudden death وهي من الحالات الحمد لله مش كتيره كانت كلها يمكن within few days or few weeks من الريكفري. زي ما قلنا احنا دلوقتي العيانين بنمشي على انتي كواجيليشن، لو دي دايما اكتر من واحد بندي ثيرابيوتيك انتي كواجيليشن. يمكن الديبيت هيكونتينيو على الانتي كواجيليشن فور هاو لونج. دلوقتي في كلام على شهر، في ناس بتقول شهرين، في ناس بتقول اكوردنج للبروتوكول بتاع الامبريسمنت الثرومبوامبوليك ديزيز عموما ان احنا نكمل لغايه 3 شهور. فيمكن الديبيت فور هاو لونج، لكن اكشولي كل العيانين دلوقتي اللي ديفلوبد مودريت كيس من اول مودريت كيس فيما فوق كلهم بيمشين على انتي كواجيليشن فور بروفيل او ثيرابيوتيك.
Thank you, Dr. Gehan. My next question to Dr. Ziad. Can we stop cytokine storm after its beginning? Why some patients didn't respond to Actemra and died only after 3 doses?
It is really hard to stop it, and we know from the data, we know from the COVACTA study, even with medications, even with heavy load of steroids and tocilizumab, there was really no benefit from using the medication. It didn't help, and the patient still went to deteriorate and eventually died from it. So it's in general, we know that once the cytokines are released, it's really hard to stop them.
Thank you, Dr. Ziad. My next question to Dr. Gehan. في حد بيسأل ليه بنستخدم البلاكينيل والكاليترا مع انهم الستاديز الجديده بتقول ما لهمش دور والدبليو اتش او وقفتهم، وبنستخدم الزيثروماكس ان هو واخد اف دي اوثرايزيشن والريمديسيفير واخد ومش بنستخدمه.
طيب نبتدي بالهيدروكسيكلوروكين والكاليترا. اكشولي الاوت كام بتاعتهم عندنا كويسه، وخصوصا الهيدروكسيكلوروكين في الحالات مايلد والمودريت والسيفير لما بيستعمل كومباينيشنز مع اذر انتي فيروس. انا الحقيقه بحكم مع الاوت كام عندي، انا عندي كانت النتائج كويسه، المورتاليتي قليله، والكومبليكيشنز او سايد افكتس اللي كانت ريكوردد ليه بره ما كانتش موجوده بالصوره السيئه دي عندي. الحاجه الثانيه ان احنا هو ما توقفش ولا حاجه، هو كان في فلكتويشن في بعض الاراء، يعني دبليو اتش او رجعت وقفته في السوليداريتي ترايل لفتره، وبعدين رجعت رجعته، وبعدين رجعت وقفته تاني. الحقيقه كان في هيزيتيشن في القرارات بتاعتها، والحقيقه ما كنتش شايفه راي واضح ليها. وعلى اون ذا اذر هاند هتلاقي ستاديز ثانيه طالعه بتؤكد على الافيكاسي بتاعت هيدروكسيكلوروكين، ستاديز طالعه من امريكا، ستاديز طالعه من اوروبا، الصين استعملوه، وكل الدول اللي استعملته بتقول الايرلي يوز للانتي فايرال عموما طبعا، سواء ريمديسيفير او هيدروكسيكلوروكين او اي اذر انتي فايرال، الايرلي يوز ليه هو انتي فايرال، فانا لازم استعمله في فتره الفيرال لود. فانا لو استعملته متاخر والعيان ديفلوبت اوريدي سايتوكاين ستورم ودخل في انفلاماتوري فيز ما بقاش فيه الرول للانتي فايرال، هو ممكن ده اللي ما يجيبش نتيجه. لكن الحقيقه الايرلي يوز للهيدروكسيكلوروكين او الكاليترا كانت نتائجهم كويسه جدا معانا.
Thank you, Dr. Gehan. I don't know if the time allows us for more questions. There's just 2 more questions and I will let you leave. I'm sorry for delaying you. Dr. Ashraf asking timing of antiviral medication, is it very important? And when should we start remdesivir? Directed to Dr. Ziad.
عفوا فيك ترجع لي السؤال، الخط عم بيعطش.
I'm sorry for that. Doctor, there is questions from Dr. Ashraf. He is asking about the optimum timing of antiviral medication. Is it important to start early, and what is the best timing for remdesivir?
Sure. So again, based on the data, in the United States, we use evidence-based medicine. So most of our protocols are based on data, not based on individual or case reports. So based on the data, the sooner you can start the medication, as long as the patient has hypoxia with oxygen saturation less than 94% and with chest X-ray changes, you can start the medication as soon as possible. You can still use it after 10 days. It's recommended to use it before 10 days of the onset of symptoms, but it's definitely recommended to use it. The study recommended up to 10 days in the United States because of some shortages. Unfortunately, we use it for 5 days, and despite that, we still get some benefit from it.
Thank you, Dr. Ziad. My last question to Dr. Gehan. What about ivermectin? Why we don't use it in the protocol?
زي ما قلت لحضراتكم احنا بنستعمل evidence based data، يعني احنا ما استعملناش حاجه غير لما بنجربها الاول. الايفرمكتين اوريدي احنا بنستعمله في كلينيكال ترايل دلوقتي موجوده، واحنا يمكن اباوت ان احنا بنسيستماتايز الداتا بس، ومجرد ما تنتشر الداتا هنشوف الاوتكم بتاعها ان كان هيتضاف في البروتوكول وفين بالظبط هيتحط في البروتوكول المصري.
Thank you, Dr. Gehan. There is only one more question. It will be directed to Dr. Rami Nabil. He is our CAM attender. The doctor is asking about the availability of remdesivir and how to obtain it.
Okay, thank you, Dr. Ahmed. Regarding private hospitals, the hospital sends the order to EVA Pharma team. Then the hospital sends the supporting medical reports together with the purchase order. Then EVA Pharma sends the order to EDA, Egyptian Drug Authority, for approval, where they consult the scientific committee if the patient is in need for remdesivir or not. Once the approval is received, we send EVA Pharma sent the order to the hospital immediately. We are at EVA Pharma committed to deliver any remdesivir order once it's received in the same day of receiving in the same day of receiving the purchase order. Regarding the governmental hospitals, the product is present at UBA. We supplied a large quantity of the product to Unified Purchase Authority here in Egypt, and any governmental hospital, educational hospital, university hospitals can order remdesivir from UBA. The process of ordering between UBA and the governmental hospitals is not under our control as EVA Pharma. However, EVA Pharma support with the distribution of the product from UBA stores to governmental hospitals. For any hospital support, we have a dedicated WhatsApp number through which we can receive any hospital inquiry regarding remdesivir. We also have an email address, hospital.support@evapharma.com. Both the WhatsApp number and the email are shared now on the chat screen, and we are glad to support any hospital inquiry regarding remdesivir. Thank you, Dr. Misbah. Thank you.
Thank you. I am now to Dr. Rehab.
I'd like to thank you all very much for active listening during our successful international webinar. And I'd like to thank all Professor Ashraf Hatem, Professor Ziad and Professor Gehan Elasal. I'd like to thank my managers, Dr. Riyad Armanious and Dr. Amir. Thank you for your time, and we have to meet again in the next webinars. I'd like to thank all of you panelists and my team, and let us meet again in other international webinar. Thank you all.
Thank you all, and thank you for having me.
Thank you, Dr. G.
Thank you, dear Professor.
You're most welcome,
Thank
dear
you.
Professor.
Thank you.
Thank you.